90% more.
90% or more? Any other percentages?
50%.
50%?
I work with the healthy mental health people.
Okay. That's contradictory. 90% or more? Any other percentages?
50%.
50%? What has your experience been with
healthy
VMAT2
mental health
inhibitors?
people.
There are two on the market, but what, with either one, what has your contradictory? 90% or more? Any other percentages?
It's muted.
Okay.
Anyone want to share their experience with either Ingrezza or Austedo?
It's expensive and not available to private practice or in patients that know.
Okay, we have other teams that deal with access, so we can always help support with that as well. What do you view as the main differentiators between the two molecules for specific patients? I just want to get a baseline understanding of if you're comfortable with differentiation, because we're going to talk about some of the differences today.
I think Ingrezza can be even more sedated with or without food, so that's that.
Okay, great. So we're gonna talk about, I'll talk about some of the differences between the two molecules, and then Terry's gonna go into some of our impact quality of life data associated with Ingrezza. So I know pharmacology is not as interesting to psychiatrists as it is to pharmacists, but really I just want to go through the pharmacology to kind of set the stage for how these molecules were created very differently, and they're just different by design overall. So VMAT2 is a monoamine transporter, and so the goal of treatment for TD is to block VMAT2 so that we can see the improvements in TD, and VMAT2 is there to transport the different monoamines, dopamine, serotonin, histamine, so it transports all these different molecules, but by doing so, by blocking the VMAT2, that's where we see the improvement in the TD movements. So tetrabenazine was the first VMAT2 on the market, and we know that tetrabenazine is approved for Huntington disease chorea, but not for tardive dyskinesia. But the reason it's here is because that's essentially the parent molecule. So it gets metabolized into 4 metabolites. And there's two of them are so there's the plus alpha and the plus beta, and then the minus alpha and the minus beta. So deutetrabenazine, or Austedo, the brand name, is very similar to tetrabenazine. Basically, what the company did was they just removed the hydrogen atoms and they replaced them with deuterium to prolong the half-life. So essentially the same molecule as tetrabenazine, just longer acting. So deutetrabenazine also gets metabolized into those 4 metabolites. And I'll tell you why those metabolites are important when we get to the next few slides. Valbenazine, on the other hand, or Ingrezza, was essentially reverse engineered. So what we did was we took tetrabenazine, we wanted to see which of the metabolites of tetrabenazine are the most active for VMAT2. So what we did here was we found that the plus alpha metabolite is what's the most active for VMAT2. So we added this valine ester here onto the plus alpha so that when our body hydrolyzes or goes through this process of plasma esterases, we just form the one metabolite, the plus alpha, which is the most active for the VMAT2. And that's what allows for once a day dosing, and it's more long acting. So here we see the side-by-side profiles. So tetrabenazine, most of the activity of VMAT2 is actually coming from the plus beta metabolite. I just told you on the previous slide that the plus alpha is the most active for VMAT2. So tetrabenazine, 35% of the metabolites actually bind to VMAT2. The remainder of the metabolites are binding to other receptors, and I'll talk about those other receptors on the next few slides. Deutetrabenazine, very similarly to tetrabenazine, gets metabolized 31% into the plus metabolites, which are what's active for VMAT2. The remainder, 69%, is binding to other receptors. Valbenazine, on the other hand, I told you we reverse engineered it. We wanted it to be the most active for VMAT2. Valbenazine only gets metabolized into one active metabolite, which is the plus alpha metabolite. So here's a heat map that shows what this binding all kind of means. So plus alpha, most active for VMAT2, valbenazine gets hydrolyzed into the plus alpha. Deutetrabenazine goes through a completely different metabolic process. It goes through carbonyl reductase. So it gets reduced into 4 metabolites, 2 of which are active for VMAT2. So plus alpha, plus beta, active for VMAT2, minus alpha, minus beta, active for other off-target receptors. So nothing to do with VMAT2. But we know to treat TD, we want to bind to VMAT2. So only 31% of deutetrabenazine's metabolites are actually doing the activity that we want it to do. The other 69% is binding to dopaminergic, serotonergic, neuroadrenergic receptors. So it's a messier molecule, a lot of other off-target binding. And we can't really draw any clinical correlations from this because we don't know what that means clinically in patients. All we know is that 31% of the metabolites of deutetrabenazine do what we want it to do. The other 69% is doing what we don't know what it's doing. And then 100% of valbenazine is binding to VMAT2. Here, this is like the pharmacokinetic profile. So with deutetrabenazine, we know when it first came to the market, twice a day dosing, it has this high peak and then this drop off. So that's consistent with the twice a day dosing. Valbenazine, on the other hand, is longer acting, once a day dosing. So we have this, the peak is more consistent. So it kind of like plateaus on the top and then it's a slow drop off. And that's what allows for the longer half-life of once a day dosing. So that was just to set the stage of the differences between these molecules. And then I'll talk a little bit about some of the clinical applications and the different populations that each of the molecules, based off of the studies that were done, what special populations they can be used in. See, there we go. So valbenazine does not have a titration schedule. All 3 dosages are efficacious. So there's a 40 milligram, 60 milligram, and 80 milligram dose. Patients can start and stay on 40, or if they need additional dosage, they can increase to 60 or 80 milligrams. They can also back down if there's tolerability issues. Deutetrabenazine, on the other hand, has this required titration schedule. So it usually takes 6 to 8 weeks to actually reach efficacy with deutetrabenazine. And then if a patient's off of the medication for like a week, let's say they get hospitalized or whatever, you have to restart that whole titration process. We also have a new formulation for Ingrezza. So there's a simple capsule formulation, which essentially means that the capsule can be open and sprinkled onto applesauce or other soft foods. So this formulation is useful for patients who have dysphagia, for example, if they have TD that's impacting their swallowing, or if they have TD in combination with another, like a neurodegenerative condition that might cause dysphagia, that's where this new formulation might be beneficial. And we studied valbenazine in a wide range of patients, different populations. So with renal impairment, we know that valbenazine does not undergo primary renal clearance. So with those patients, there's no dose adjustment required. With deutetrabenazine, it was actually not studied in renal impairment, so we don't know how those patients behave. With hepatic impairment, valbenazine, there is no dose adjustment for mild hepatic impairment, but if patients have moderate or severe, the recommended dosage is 40 milligrams. Deutetrabenazine, on the other hand, is contraindicated for hepatic impairment, and then for geriatric use, so patients greater than or equal to the age of 65, there's no dose adjustment with valbenazine. But with deutetrabenazine, their label says that caution should be used because they didn't include enough of those patients in their trial to draw any conclusions. And then we also studied valbenazine in a more real world population. So we allowed anticholinergics. About 30% of patients in our study were on concomitant anticholinergics. So we know that's more real world. Deutetrabenazine, on the other hand, did not allow any anticholinergics. And with regards to hyperprolactinemia, there's no restrictions, no warnings for valbenazine with hyperprolactinemia, but deutetrabenazine does have a warning and precaution for hyperprolactinemia, which was based on 10 studies. I know I went through that really quickly and it was a lot of information. Any questions on those slides? Do any of these populations resonate with your clinical practice? Okay. Great. Well, if there aren't any questions, we can also answer questions at the end. I'm gonna hand it over to Terry because she's gonna go through some interesting new quality of life slash functional impact data that we released with valbenazine recently.
Well, while you make that transition real quick, can we just remind everyone, if you're in the room, have you signed in on our sign up sheet? There's a couple of them going around. Which we-
You can tell she's a pharmacist, can't you? She goes through that so smoothly. I was sitting there still learning 5 years later from Ava. So what's cool about us working together today is, you know, she does a really good job with talking about the science and helping you to be really confident in your choice with deciding how to treat tardive dyskinesia. There's 2 options on the market, and she just did a really good job, I hope, of helping you all feel very confident. I have this over it.
Oh,
Sorry.
I was like,
Yes,
sorry.
because I just didn't want to go
Okay,
into
okay.
that, so I hope that she made everybody feel confident about the choices that you have in front of you in regards to using Ingrezza, because we just heard how uniquely selective it is to the VMAT2 protein. And we heard also, you know, that it's safe. While she's the pharmacist, I've got the psychology background, so I'm gonna be a little bit more touchy-feely on my side of the presentation. And I want to build on the confidence that Ava just gave you, and start with just thinking about how you can offer Ingrezza to your patients. And I think that we can all agree that starts with screening. And we all need to do a better job with screening in the mental health field. There's 800,000 patients in the United States, we know, at least, that's an estimate, with TD. And we know that roughly 60% of them are undiagnosed. So please take for a minute and think about that. You know, what can we do together in the mental health field in regards to those 60% of those patients that are out there untreated? And, you know, I think, you know, it starts with using the DSM, of course, to get to the diagnosis. But I also want to just ask you all, is everybody in here pretty familiar with the AIMS? And are you using the AIMS to help screen for tardive dyskinesia? If you're familiar with the AIMS, please raise your hand. Yeah? Okay, I want to make sure that I wasn't going to assume that. So it seems like it's pretty common and here, commonly used. And just to make sure that everybody else also level set, I did say this, but I want to emphasize it. The AIMS is a very helpful tool to measure the severity of the movements, but remember, it's not a diagnostic tool. It's the DSM that's the diagnostic tool. And the AIMS helps you get a baseline of the severity of the movements. And then it helps you also determine how progression is happening with the treatment that you offer, right? So the AIMS also, though, is just a number. And this is where the psychologist in me comes out and says, we need to do a little bit better than that. Is there a way that we can complement that number? And there's a really hot topic right now amongst all mental health diseases, depression, schizophrenia. Anywhere you go to these sessions, you're hearing for at least the last year, where a lot of people are talking about assessing the impact that the disease has on a patient's functionality and also how it impacts their quality of life. So Neurocrine's just going right along with that kind of new shift in thinking. And I think, you know, it's a really great thing because we're giving the patient a voice. As a matter of fact, yesterday I was in a session that was talking about the future of DSM. And I heard them say that there's a subcommittee looking at how we can incorporate disease impact and quality of life into the new future DSM. And so I feel like the research that Neurocrine's doing in regards to tardive dyskinesia is so timely. And also we're really proud of the fact that we are the first to really come out with data that supports patient-reported outcomes. And that's what I'm going to be talking with you a little bit about today. And this is a study that has been validated as far as the tool that I'm gonna be talking about, which I guess the study is validated, the tool that we used to get here is validated. It's gonna be published for the first time sometime this summer. But Neurocrine came up with one of our own tools to use to assess impact and functionality on quality of life. And in this particular study I'm highlighting, we also embraced patient-reported outcomes that you all are probably familiar with. Anybody in here familiar with the Sheehan Disability Scale? I know you use that a lot with depression and anxiety. And also maybe the Euroqual Visual Analog Scale. That's that real simple scale where a patient tells you how they're feeling, their overall health on a scale of 0 to 100. I see some people nodding their head. And then we added the tardive dyskinesia impact scale to take a look at how TD is impacting patients and their quality of life. And our study was really a groundbreaking phase 4 study that looked at the impact of patients over the period of 24 weeks. So this is this new tool that I said is validated, that is part of this assessment. And this is kind of like new breaking information. Like I said, it hasn't even been published yet. So you're kind of seeing something that's brand new. And some of you, I know, Dr. Najafi's already heard about this. Probably a few of you had, but for many of you, this is probably new. So I just wanted to give you a very brief, look at what we're assessing. Again, AIMS is just a number. Looking at the severity of movements. This is looking at so much more, don't you think? Look at these 11 areas that we're looking at. In the past 7 days, how much was your speech affected by your TD? How much did you have problems with mouth noises, swallowing, gripping, handwriting, walking, balance, pain? And then we had some real social and emotional, again, the stuff I like. Questions surrounding patients and how they felt about unwanted attention, feeling embarrassed and feeling self-conscious. So you want to see the results? What do we find out?
Yes.
Would you imagine that patients are pretty impacted by TD? You're right.
Yes.
And I could even show you this as far as all those areas, how much treatment can reduce that impact. So this is 24 weeks out. And what we saw as far as the improvements, which is, the percent decrease from baseline to week 24 and all of those areas. And I think it's probably no surprise to anybody that, some of the items that had the greatest impact on the TDIS score at the end of treatment were feeling embarrassed, feeling self-conscious, and unwanted attention. Anything else up here strike anybody as surprising? Are you surprised that we're assessing it? Are you surprised at the results that you're seeing? I'm happy to open this up for discussion. Does it seem like these are areas that we should be asking about instead of just doing names? Can we agree on that?
Yes.
Yeah, I love it. Do you think that you could do a better job of asking these questions of your patients when you're assessing their
Yes.
TD?
Yes.
I love that. Thank you. We're here at APA, so I should probably, ask this question because the APA has guidelines about this. How often should you be assessing your patients for TD that are on antipsychotics? I think
Every time you see him.
every time you see him, I love
You
it.
have to do-
And I didn't plant him there to say that.
You have to observe.
Yes,
Look at him, head to toe.
every clinical encounter, you should be looking for it. So just so you know, I'm not asking you every clinical encounter, do an AIMS, every clinical encounter, ask about all those 11 areas. You would chase me out of the room if I was asking you to do that in your 15-minute appointments, right? You'd be like, this lady's crazy. But in reality, the actual formal screening of AIMS, the APA has guidelines on too. So first and foremost, every clinical encounter, look for it. How often do you think the APA says you should do an actual AIMS for patients who are on antipsychotics?
Every 3 months.
Every 3 months, I like that. I like that. You're basically right. It's like 3 to 6, excuse me?
Okay.
Okay, it's like 3 to 6 months, particularly for your patients at risk. And, you know, at least at the bare minimum, the APA says once a year for patients that aren't at risk. But let's just talk for a minute about who's at risk. And it's probably a lot of your patients. Who do you think are the patients that are at risk for TD? Who are those patients? Women, you're right. Good one. Any other?
I think that this training
Huh?
should be expanded to non-psychiatrists too, because majority of the patients, they, from, in my experience, they go to other specialists rather than psychiatrists because they get fed up with all of the side effects of medication. They don't know what to do. I remember the time that I was hoping and wishing to have a medication. Now, the first one was introduced a few years ago, and the second one, I'm very happy for that. And
Thank
I
you
think
for
that a
that.
lot of patients are not going to psychiatrists because of the side effects of medication. Once we tell them the side effects can be controlled, they would be much more willing to take medication.
Yeah, I love what you say. You know, we have advanced so much in the TD world. I was a clinician in a hospital like 100 years ago when the rocks were soft. And I remember patients would get TD and it was a big deal if it was even documented because so what? You're right, there was no treatment. But you know how far we've advanced now? We have advanced to the place that we are now even not calling TD a side effect. It's its own disease. It's got its own DSM diagnosis. And that is helpful because now we have medication for it, like you said. So you have to make sure that you're giving these patients the diagnosis because you know the insurances aren't gonna like it if you're not giving them these diagnoses. You have to give the diagnosis based on the DSM, and then sometimes they ask you for that AIM score, right? And also for your own clinical knowledge, you wanna know what that baseline was on the AIMS so that you can see if treatment's working. A few months later, like Dr. Dajapi said, 3 months later, you do the AIMS, see if it's improved. You know you picked the right medication. You know that VMAT2 inhibitor is working. And that's how you can, you know, prove to the insurance company you're doing the right thing, right? They usually demand that they want to see you're doing the right thing before they give you another month's worth. So thank you for that statement. I really, really appreciate it. Let's see how we did with the other patient-reported outcome tools that we used in this study. This was that EQ-VAS that I mentioned. So easy and so quick. You probably all are familiar with it. Say, how are you feeling with your overall health to a patient on a score of 0 to 100? And this is really, really kind of interesting to me. This is what stands out about this data to me. The average adult in the United States scores this, like an average adult without necessarily a psychiatric diagnosis, scores themselves at a 78.8 on a regular basis, like on any given day, between 0 and 100. That's how they think their overall health is. After treatment with Ingrezza, these patients, after 24 weeks of treatment with Ingrezza, were just slightly higher than the average adult on how they rated their overall health. That's pretty impressive. They started down here, right between, you know, like around 60 and 70, and they went all the way up to 79.5. And that's a little bit higher than the average adult. Again, showing that treatment is working on their quality of life, right? That's the EQ-VAS. And then on the Sheehan Disability Scale, we assess their disruptions to their social life, the disruptions to their family life, just making sure you're oriented. The improvement means that the scores are going down. And we saw, improvement in both of those areas. And now I'm going to tell you something else about the way we looked at this data that might surprise you. I'm not going to go into the details of it today because of time constraints, but Ovid, I could certainly hook you up with a medical science liaison who can come to your practice, sit down with you and look at the data, cut a different way. I'm just going to tell you we have it. Or an MSL can even come into your practice and do a presentation for all of your clinicians and talk about the data in more detail. But one thing that we did, because we were curious, we were wondering, is treatment as effective for patients with just mild TD? as it is for patients with severe TD? Or the other way around? Is treatment more effective with patients with severe TD versus mild TD? You might not see much improvement. And guess what our data showed us? The same level of efficacy for Ingrezza in both patients with mild TD and severe TD. And I'm hoping what you're hearing me say is, if you're seeing mild TD and you're thinking to yourself, it's just mild TD, guess what? These improvements were including patients who had mild TD, and these are pretty robust improvements. So I'm just asking you to start thinking about making sure that you're not passing on those patients with mild TD until they say something to you. Think about a patient with mild TD not getting that high of a name score. But now think about that patient with mild TD and you start asking those questions that I showed at the beginning, those 11 areas of, are you having embarrassment with that small movement I'm seeing? Are you having any pain? Are you having any trouble walking? And asking those impact types of questions, you might find that that mild TD patient really actually is having issues in their quality of life and really might respond. Well, we know now because of this study that they do respond to treatment. The other thing we did with this data is we looked at the underlying diagnosis because we were curious. Patients with mood disorders versus patients with schizophrenia or schizoaffective disorders. Would one or the other, respond better to treatment? And guess what we found? Equally responsive. Is that what you would have thought? Would you have thought that one subset of that psychiatric diagnosis would be easier to treat than the other? Like mood disorders might be more responsive to treatment, or schizophrenia or schizoaffective disorders, or would you have thought it would have been about the same as far as how patients responded? Yes.
I'd like to take you back to the prior to invention and production of this medication. When we were dealing as psychiatrists, practicing years with medications that highly causing EPS, and that was in our mind when we were giving that medication. And we had other choices too, but first trial and error. That's the practice of psychiatry. Giving let's say Risperdal or Haldol, Tegretol, or to really that. So the Haldol Risperdal was very common. The idea was to give the medication to the patient who might not develop EPS. We were hoping, but many of them develop EPS mild form of it. The first thing we used to do before this medication were introduced to change the antipsychotic to another one, with the hope that the patient is not going to develop the EPS and other symptoms. I've had patients coming to my office with their neck in one side because of the spasm and the tardive dyskinesia, and I didn't know what to do. And the patient was ending up to other doctors for help. Now we have the medication. What would you suggest? When the patient comes in with the first few symptoms, should we go ahead with continuing the same neuroleptic and add this medication?
That's how we studied it. That's exactly how we studied it. The patient's psychiatric medication regimen did not change in our studies. And one of the things, like Ava said, a lot of them, were on medications that like Reglan or Cogentin that you might think, well, we know now that worsens TD. We let those patients stay on that medication and we just added the VMAT2 inhibitor. We have just, like you said, come so far. In fact, we've come so far that, and I'm really glad you brought that up. Thank you, because I might have forgotten to mention this. We've come so far that we don't even really need to use the term EPS anymore because it's just so broad. Now we have treatments for dyskinesia or for dystonia. We have treatments for drug-induced Parkinsonism. We have treatments for akathisia, and we have treatments for tardive dyskinesia. But you know what's really interesting is those treatments are often different. So if we call all of those movement disorders EPS, That's kind of not so great if we have different treatment recommendations for all of those movement disorders. So we're actually, I think, at this point, trying to get away from calling them EPS, because it's just not fair to the attention that that specific disease deserves in regards to the specific treatment it deserves. Like I just said, cogentin is not gonna be good for TD, but we know it works for what? Drug-induced Parkinsonism, right? Yes.
I agree with that, but how do you call the disease when it's caused by drugs?
Well, I think that we'd have to probably have like the board of directors and all the people who were consulted with the DSM-5.
TSM is mostly false.
The DSM is mostly false. Okay, well,
Scientific.
So in the pharmacy world, we usually think of side effects as something that can be resolved, right? If you change the medication, if you remove the medication, it can be resolved, but then a disease is a lot of times permanent, right? You can control the symptoms, but you don't always reverse the disease course. So TD, we know oftentimes it's persistent, permanent, so that's why it's considered a disease, even though it's caused by medication.
But that's a misconception. If you stop antipsychotics in the natural course of TD, do antipsychotics, 90% of people don't have it when you're following.
oh wait, hold on a minute, that's news to
Based
me.
on old research, yeah.
So do you have a citation for that? Because we have, there's
I
a,
cited a textbook,
it's in a textbook?
my textbook,
Oh, that you wrote?
yes.
Can you share that?
Yeah, I mean, we of course would need to know that because we actually
It's not
cite,
irreversible, that's a common mis-
we cite, research that the first author is Cloud, that says that 13%, around 13% sometimes resolves, but that other than that, it doesn't resolve. I mean,
Old research, biology literature, 80s, 90s,
so,
shows majority resolves if you can come off the antipsychotics. The problem has been that in schizophrenia, we don't take people off antipsychotics. So it's fine, you give something for that, but that's not a disease, that's a drug side effect. If it goes away, which it actually does in most people, that's a drug side effect. So to call it a disease is a little question.
So in your experience, does removing the antipsychotic or changing it earlier than later usually resolve the TD, but if you change it later, it's not permanent?
I don't, it's not my experience, I mean, I have to look at the older studies, but by and large, you just need time. Actually, it's my clinical experience. You take somebody off an antipsychotic, especially with mild to moderate TD, in about 6 months or longer, it's gone, in most people.
Well, but in the meantime, those 6 months, they have a really horrible,
It's not, why not? I mean, I had a patient on Geon on high doses and took her off. She had very bad TD, 20-some-year-old. It was gone in 3 to 6.
right, and I have,
That's a bipolar patient, so patients that you have the option of taking them off. the list. In some patients, you don't have the option, and of course, this is a good point to use something, but to your point, it's not like everybody has to stay on antipsychotic and you gotta add something. Some people can come off. And it's not a correct view that has been passed on, that it's irreversible. That became from the experience of the 60s, 70s, when these drugs were being used for schizophrenia and we weren't taking people off. So the TD continued and people called it reverse, but it's not if you take it off.
one thing I think we
When
could
we
certainly
talk-
agree on.
if
is
you
we
don't
need more
mind,
research.
I would like to really take you back to the earlier that the medications came for TD. We used to give, in Iran, when I was practicing, giving Ativan, 2 milligrams BID, in every patient on neuroleptics.
Mhm.
Was a routine. And then when it came to United States, Ativan was not popular, cogentin, 2 milligrams became popular. Every patient was on neuroleptic, was given this medication as prevention. Would you advise to do that with the new medication?
We
that
don't,
could be-
I don't think that an insurance company would probably,
They want
approve
to
of
have
VMAT2 inhibitor
I see.
you know,
Not as a
prevention.
prevention, but if the first few symptoms
Yes.
start that the patient doesn't recognize as a side effect, we do. I have had patients at the
I
emergency
think your
room,
point was good, that
yeah,
can help with akathisia. But it's never been shown, that kind of thing doesn't.
actually Parkinson's, yeah. Cogentin is good for Parkinsonism, akathisia, usually propranolol.
Benzos or-
And for the torticollis and all that,
Yeah.
it's also propranolol.
Yes.
But to talk to you, depends upon how severe. I've had patients, high functioning patients on 5 milligrams of Abilify to augment the depression. They have the most severe TD, or at least what we call it, not maybe TD, but you know, just a movement disorder. And then she could not even sleep, she could not work, she would not go to work. And we had to put her on this type of medication as soon as possible, and it took a year to get over it.
Thank you for that.
Yeah.
You had something you wanted to?
Yes, first of all, Dr. Walton, to most of the time, psychiatry, child psychiatry and addiction risk. So actually, I'm using Reza and actually it's a very good foundation. But I would like to actually ask Dr. Banti that we need to invite him to talk to us for SIPNA and give us more information about that because I'm really trust Dr. Banti because I know him. And unfortunately, the studies that now are out is just, telling us that even though if it is continued medication, the TB is gonna continue, and just only 15% will, go away altogether, so. It's very encouraging that what Dr. Don said, I
Yes.
trust her 100% because I know him, I know this book. So that's why it's just like out of, the knowledge of today's session. But I really would like him to hopefully accept our invitation to talk, to us.
I would love to hear more about that too.
Yeah, it's an older literature. It's an
So
older-
I'm sure it's all here.
The one thing that you said too that's really great that I appreciate the emphasis on is in our studies, we did see by far most of the patients return to their baseline after Ingrezza was withdrawn. We did a washout period in our pivotal studies, our long-term studies of 4 weeks. And it only takes about 4 weeks for those movements to come back. So, it's certainly not a cure, but the VMAT2 inhibitors and Ingrezza certainly manages the movements. And, at least insurance companies agree with us that it's a disease that patients deserve to have treatment for, because otherwise, if they thought that it was just a side effect and all the patient needs is to go off the antipsychotic, they wouldn't be letting patients be taking Ingrezza, right? And insurance companies are hard people to convince. So I think there's probably mixed evidence out there, but I've been working for Neurocrine for 5 years and this is the first I've heard of this evidence. So I'm like you, I'm intrigued. I would like to hear more about that. But we do call it an irreversible disease. And that's what I have been trained by, some of the experts in actually not just the United States, but the world. But I'm always open to new ideas and to hearing about new evidence.
The question is, how much movement is too much?
How much?
How much abnormal movement is too much?
Well, that's what we're talking about. It shouldn't the
It's
patient
just-
say,
yeah.
right?
It may not need to be so severe,
Mhm.
to have an impact. A slight movement can have an impact. The second question we've been talking about is it reversible or is it irreversible? Well, in cases that maybe use our first generation, majority of that use was for severe. That patient population, we really cannot take them off that medication because the disease, schizophrenia, will exacerbate the horrible consequences. Where do we use our second generation? Schizophrenia, yes, bipolar disorder,
New disorders.
bipolar depression, MDD,
Done.
and off-label use.
Yep.
So significantly larger patient populations are exposed. And their adverse population also.
So we're
But
seeing
when we
increases.
see the movements, with some of those patients, we have the option of taking off the dopamine blockers.
Yeah,
And then we have an option to either implement the VMAT2 ultrasound, depending on severity of the symptoms, and see how much longer.
There are options. I mean, again, we're talking about patient voice and your clinical assessment on how risky it might be to the patient's psychiatric stability to take them off. And every patient's gonna be different on that risk level. So you make a great point. But yeah, I mean, it being for the most part an irreversible disease, you are right in that the literature that I quoted is older literature, and you said 15%, I think I said 13%, but we know that some patients do resolve. I've just always been under the impression that it's very few of those patients do have resolution of their tardive dyskinesia movement. So it's a very interesting topic. Thank you for bringing it up.
You know, as a clinician, I'm very concerned in the way pharmaceutical, and you and then other ones, they were promoting this product. What we see in the marketing, almost saying these patients walk around, I'm talking about TV, commercial. But what is this? It's being advertised as as a disease. It is not a disease, okay? It really, I don't think we are doing a service to the community for having these people walking around having, oh my God, I have schizophrenia, I have bipolar, I also have dyskinesia. This is something I think is being, of course, a marketing. I think it's not doing a service, fair service to the community, especially to this patient population who already are being stigmatized, This is, sometimes I think pharmaceutical company, we're thankful we have them, but they're just a little bit going beyond some of the, let's say, maybe ethical, humanity, a little bit, they're going too far.
That's the marketing department. These are scientists.
Thank you. We actually, here today, I mean, Ava asked at the beginning if you know the difference. We are not here in a promotional role today. I hear what you're saying about marketing.
No, in general, you
In general, okay, got you. We're here to talk about the disease and that there's treatment for it, education, but not promote. Yes.
But I don't think the label is that much important. When we are dealing with tardive dyskinesia, we want to label it. Of course, I understand it's not disease, but it's something that we have to take care of. So what the difference it makes, what name we want to say. There's something that we have to treat, and that's good that we do have that.
I agree with you. Exactly. Not at all arguing against treatment. I was just addressing the point that sometimes you can stop it too. Yeah. And I apologize, I have to go. I have to leave.
By the way, he is one of our esteemed colleague, one of the, I think, top 5 experts in pharmacology. Okay, that's a fine.
Yes.
Yeah, very proud to have him on board, sir.
It sounds like the people that are working on the future DSM might be interested in hearing your thoughts, because the DSM really defines is, the diagnosis of diseases.
Yeah, it's just a textbook of pharmacology. Psychology.
But
But the references aren't in there. Not good for that.
Okay.
I was just Googling it on my phone.
Okay.
There are old references. I mean, they range, maybe 80, 90s on the high end, 50% they sometimes report, and 15 is pretty low. So it's some people reverse, some people don't. And I think it's good to have the option to think about going on as well.
Yeah.
And if you don't get better, it's good to have the options to go on.
Yeah.
And just remember too, like taking away that antipsychotic, remember, is not feasible for some patients. I think we should agree on that, right? Because if it was so easy to just take away the antipsychotic, that's not the case, especially with some of those more debilitating diseases like schizophrenia and schizoaffective disorder, which is why they're called antipsychotics. I think we can agree with that too. So you would have to find one that still manages the psychiatric stability. And we know that antipsychotics save lives. So you don't want to necessarily just take off a patient off their antipsychotic if you're worried about the movements, because that could make a person actively psychotic and possibly harmful to themselves or others.
Yeah. It's not an option, actually.
You don't think it's an option? Yeah. Well, there's lots of options and medications you could try, but just to take a person off their antipsychotic is just not always feasible. We know that. So we know that this is something that you don't have to do when it comes to Ingrezza. You just add it to the regimen. You don't have to mess with what they're on if it's working. And, points well taken. Oh, yes.
I just wanna mention whatever, I think Dr. Shami said before, that it's very important that also primary care physicians be informed. In my case, I had a patient that went for another side effect complaint, and primary care just said, you know what, this is all because of this medication, take it off. And as we know, so he became more psychotic and like the order of protection. So,
Yeah,
and-
there's a great example. Thank you for emphasizing what I was just saying in a real world. You just take away their antipsychotic and their movement stop, but then what happens to their psychiatric stability? You have somebody putting out a protection from order against
So
you.
it's very
Yeah.
important that said that primary
Yeah.
care physicians also be informed.
Right. Thank you. I appreciate hearing both sides from the audience, so it doesn't sound like I'm being biased. I definitely appreciate that. Thank
And
you.
one question for you all, do you view TD as a progressive disease or a static disease? Like, do you think patients start out with mild movements and then it becomes severe? Or do patients wake up one day and they might have severe?
The way I have seen it, it's very severe from the beginning. And it's not like an increasing, it's usually very severe, suddenly it happens. And then you have to address the, treatment, and it takes a couple to a few weeks until it goes away.
And also, we don't see patients on daily basis, so you see the patient comes 3 months later, you will see that patient doesn't complain. But you see just the mouth movements all over, and I will ask them how long it's going on, so you cannot give us the answer, so.
Because they might not be aware of
Yeah.
that, right?
I've had patients on both spectrums, for some stay the same, maybe mild. But for many actually it started mild and advanced.
Because the current literature says it's a static disease, but we hear a lot of times it might start out mild and like, I guess it's patient dependent, yeah.
We have a lot more to learn in that area. So it's interesting you all said that. Yeah, thank you. So I'm just going to wrap up now. It's a great commentary from all of you. Thank you so much. To be fair and balanced in our role, again, because we are in a non-promotional role, we do, have to just touch upon important safety data. I do want to tell you that in this particular study that I talked about today, which is called Connect Pro, our safety analysis was very much in line with what we saw in regards to our pivotal study that got, the FDA approval and our long-term studies in regards to the AEs. And of course, we know that, one of the AEs that we see most often is somnolence and sedation, which we do have some data that we can share with you if you're interested, that does say that that can be transient and managed as long as the patient can tolerate Ingrezza. I do also need to mention that Ingrezza can increase the risk of depression and suicidal thoughts and behavior in patients with Huntington's disease. That's really important to mention. Ingrezza is indicated for use of chorea in Huntington's disease. So we do want to make sure that if you ever do use it with this patient population, if you do know about this warning. And of course, contraindications are actually kind of minimal when it comes to valbenazine or Ingrezza. You just don't want to give it to people that have a history of hypersensitivity. Duh. Okay, we're good with that. And there have been cases of angioedema. Of course, if that happens, you need to discontinue Ingrezza, as well as with NMS. If any signs and symptoms of NMS arise, you would want to immediately discontinue Ingrezza and monitor for signs of reoccurrence after you've discontinued it. In regards to QT prolongation, it's not significantly clinical to worry about when they're at dosing that we recommend, which is the 40 milligrams, 60 milligrams, and 80 milligrams. However, for patients with a risk of a prolonged QT, you do need to assess that QT interval before starting them and increasing the dose. Lastly, we know that it can cause Parkinsonism. You need to watch for Parkinsonism, and if any Parkinsonism symptoms occur, you would want to reduce the dose you're on or discontinue. And I already talked about somnolence. And with that, I will just leave up on the screen some of the key takeaways of the study that I just talked about. But I just really want to emphasize that after 24 weeks of using Ingrezza, we saw patient-reported improvements in quality of life and functionality, which, you know, is really a hot topic now across all disease states. And we really want to share that that transfers over to TD as well. And that's just doesn't matter. That's regardless of what their underlying psychiatric condition is or the severity of their movements, whether they were mild, moderate, or severe. And unfortunately, I have another appointment that I don't want to keep my physician waiting for. So I am going to finish by letting Ava find out from you if there's any lingering questions. But before I run off, personally, I want to thank you for the commentary, the engagement. You all were great, very welcoming. Thank you so much. And also thank you to you, Ava, for doing such a great job.
Thank you, teamwork. Thank you. Are there any last minute questions or discussions, anything you want to talk about?
Parkinson's with Ingrezza, so that's what we sometimes we see when people they get on Ingrezza, they do great, and later on they start having tremors.
And does backing off on the dose of Ingrezza usually help resolve those tremors?
Sometimes it helps, sometimes, you know, we have to back off that much that almost like discontinue. So.
Okay, so in our studies, we saw 3% of patients had drug-induced Parkinsonism, but what we hear in the real world is that it might be a little closer to like 10 to 12%. So is that more consistent with what you're doing in your practice?
Especially again, most of the TD people that they have, they are women. And most of them, you know, those are maybe very sensitive to this.
Yeah, usually, if patients lower the dose, it resolve, but if it doesn't resolve, you know, 40 is our lowest dose of the medication.
Any differences between Austedo and Ingrezza? Why people should choose this and avoid the other one?
Do you have a specific situation in mind?
Just in general, and also, like,
So obviously they're both FDA approved, right? They're both efficacious. We know they both work. We talked about some of the differences in how the molecules are designed. So something to keep in mind, even though we don't know the clinical correlation, but also with specific populations like the hepatic impairment, the renal impairment, geriatric patients. Those are areas to consider if you have those types of patients in your practice. Anything else? Okay, thank you so much for having us.
And you're gonna conduct some business.
Yes, yes.
So that you be.
At this point, thank you very much. I appreciate it.
Thank
You guys
you.
did a great job. And at this point, I'm going to ask Dr. Beliana to give the report of last year activities of SIPNA.
Hello, everyone. Salon Batami. First of all, thank you very much to the judge and Hawa and Perry and Adam. And from all of you, I would thank a lot, Dr. Ruin, Rafayan, that you were our connection with this wonderful group, that they arranged this very good launch and very good place for us. Thank you very much. And
Sorry, did everyone sign in?
You gotta say-
So we'll wait a few minutes to see if it's fine.
Thank you, thank you.
We are recording everything. Yeah.
We can read your name. Is it this one?
Isn't that somebody put it down?
Where's the 13th? But you have the 13th?
No.
I have the 13th.
دیشب میگفتی نمیاد هنوز
خیلی خوشحالم نمیگن که تو آخرین لحظه ما رو در دلهوره نگاه
ولی سورپرایز خوبیه سورپرایز خوبیه
بیشتر میده جان بیشتر میده جان ما خوشحال خب تا صبح نخوابیدم I don't have any idea what you guys Thank you. میشه برای محمد برای علی شما که نوشت ما اسمتون نوشت منم نوشت آزور خودم I'm glad that we didn't have that many chairs left. Now when it's going to be my turn? That should not be. Hey, Baba, منتظریم اینا برن دیگه. غذایی که ما خوش شد نمیبرن. غذا رو باید یا تمامش کنی یا این شام برگردیم.
بله گفتن که بالای
دفترتون کجاست؟
اینجا کنن.
مورد دیگه در مورد رفتن همون آقایی که در مورد DSM صحبت میکرد تکس میکرد
میگفت من فارماسیست اونجا نیست
نه رفتن گفتن یه جلسه دیگه دارن و رفتن ولی صحبت جالب بود در مورد DSM
مسئله اینه که کارد دیسکنژیا با دیسکنژیای دیگه فرق دیسکنژیا دیگه اینا دیزیز نیستن اینا قاعدتا دوا رو که قطع کنی میرن کارد دیسکنژیا دوا رو قطع کنی بدتر میشه برای اینکه می‌دونی
ببخشید فقط گفتم که غذا رو یه 10 دقیقه دیگه میبرن اگر کسی میخواد for the second or whatever they will take the food away in 10 minutes so if anyone wants for the second please go ahead and have something.
let's get some more.
بله بله.
برای اینکه
واقعا اوکی. امروز صبح رفتم برج ولی
for my این دیتو داروهایی که دیتو ساپرس میکنه موومنت هم ساپرس میکنه. وقتی شما اون فشار رو از روش برداریم موومنت ها شدیداً زیاد میشه. بیشتر مواقعی که ما این تاریخ دیسکنشیا رو میبینیم موقعی که دوا رو قطع میکنیم یعنی که یارو توی اینترسایکالی که برش که میداری و دوا شدید میشه. اون وقت به نظر من این دواها رو باید داد بشه بعد وقت یواش کم کرد تو سی بود ریترنینگ
یه جورایی ترانزیشن
اینم ریترن یا نه حالا دیگه چون نهار اینا رو
من رشتم توی بچلرزم خیلی در مورد بیهیویر و سوشال سایکولوژی اینا بود. قسمت مثلا مدیسن سایکولوژی برام جدید سره.
بله به حال خوبه که بدونی مثلا همین تری سایکولوژیست ولی خب وارد این کار شده حالا شده ساینتیست اینا میام همیشه میاد آفیس ما
همین خیلی بلند
نه به عنوان مریض به عنوان همین
drug rep
نه رب اینا بهش میگن به اصطلاح ساینتیست میاد با دوا از دوا به عنوان نحوه کار و چجوری و در چه موردی این استادیا رو میکنه. رپا میگن که آقا این دوای ما رو بنویسیم ما بیشتر سلف
میگم به دکتر گلنشون خیلی جالبه که اینجا they almost advertise like pharmaceuticals. In Canada they don't really do that.
بله
It's like very much against ethical protocols. So it's interesting to see it here.
اینجا شما هر طرفی به چرخی باید یه چیزی بفروشید. کارهای بسیار بد گوش کردن درد است. یه دوای گرون قیمتی میاد مریضه خوبه میاد این آگهی رو میبینه تو سریع میگه که اینو به من بدید بگیم آقا من خب ترای به این علت مثلا قیمت شما دوای گرونه مثلا این دفعه $1800 در ماه میدونی ارزون نیستش
بله
کانادا هم دوا ارزونه همین هم گوش نمیده
شاید نسبت به اینجا ولی
کم میکنم
نه تا جایی که من میدونم نه اکثرا it's very illegal نمیخوان که یه جورایی
خرجشون رو زیاد کنم
نه اصلا بخاطر اینکه از نظر اتیکس میگن که پیشنت ها مثلا همینطور که گفتن میاد دفتر تو بیرون ما اینو میخوایم ما اونو میخوایم انگار رفتن گروسری استور
بله البته یه خاصیتی هم که داره اینه که واقعا رشته سایکاتری یه مقدار بسیار میدلاین شد و مرچیز شد علت همین آنگهی ها مثلا کسی در سالهای 1980 کسی دسته دیپرشن حرفی کسی نمیزد انقدر این پروژک آگهی داد همه روشون واش شد اومدن و دوا رو خوردن شدن
یه جورایی نورمالایز کرد سایکاتری
بله نورمالایز
یه نفر نه بله بیدرست یه خانمی اومد ولی اسمشون
اوکی
یک باید نبود Share with you. Whether the limit was, and listen.
Thanks for sharing my thoughts.
Yes, the rest there. Said that would have potential. And from the room that I used to have. Vegetarian. Ethiopia is the very different from. She has been part of the group that came from New York. We had that dinner last time. That's your. The first and I will send very difficult to it. And then there are in the name of the city that you are born. Right? There are. And in 5 years. Being done in several. Is not active practice. He said that I'm retired. I said you should not be retired because you're not. He had an accident, it was not able to talk. Comfortably for a long time and then. Now I want to take it.
با اجازه همگی جلسه رو شروع کنیم برای اینکه برخی از همکارا باید برن و چکاپ کنن به فرودگاه برسن و خیلی امروز شهر رو ترک میکنن. به هر حال همه شما خوش آمدید. الان 44مین همونطور دکتر نجفی که تا حالا رئیس بودن حالا میشن پس پرزیدنت و از این لحظه من میشم پرزیدنت و دکتر معتمد با الکشنی که الان تنها ما کاندید هستیم هم پرزیدنت الکت 44مین انیوال میتینگ سیپنا رو شروع میکنیم. همطور که میدونید ما همیشه یک قدردانی داریم از بنیانگذارانی، از کسانی که دکتر سیاسی و دکتر کرمانی و دکتر تهرانی و دکتر سیمونیان، دکتر پهلوان، همین کسانی که دکتر میرابی که این گروه رو شروع کردن تا اینجا آوردن. از طبق گزارش میبینیم که این یه افتخار بزرگیه که یک همچین گروهی الان با هر چیز کیفیتی که داریم is allied group of APA. این افتخار بزرگیه. به نظرم همه ما و خصوص جوانانی که بعد شما این سیپنا دست شما خواهد بود، اینو باید و به پیش ببریم. سال پیش بعد از 43مین جلسه ای که داشتیم، کارهایی که ما کردیم قبل از گزارش طبق دکتر میرابی میخوام که هممون یکی یکی خودمون رو معرفی کنیم و بعد میتینگ رو شروع کنیم. من از خودم شروع میکنم. من دنیس گلیانا، من از سایکیاتریست از ایلینوی و در شیکاگو لند پرکتیس میکنم و از همجا به دکتر میرابی شما شروع کنیم.
محسن میرابی، یوستان تگزاس. Estefan Simonian, Estefan Simonian, I'm psychiatrist, I'm in California, blended practice. شهری دوتونویش از اولنده هستش. دوستان اساتید بزرگ گرامی در گورستان کالیفرنیا برای حاضران چهره آشنا رو می‌بینم و چندین چهره جدید دارم در جلسات سینا فعال باشیم و می‌دید و بتونیم به اهدافی که سینا دارید به آقای دکتر دیگران خودشون برای ما در چند آینده حتما
بیان میکنم تنبیه کنم که این اهداف برسیم.
سلام همگی، من عبدالرزاق صبوری هستم و پزشک اطفال و بزرگسال و من از انقلاشی دانشگاه تهران با دکتر محمد از اینجا با ایشون آشنا بودم. ارتباط درشون هستیم. من در حاضر در شهر وایسلیا که سنترال کالیفرنیا مشغول هستیم و یه رزیدنسی پروگرام داریم که برای اکادمیک انجام میدیم.
البته من خواستم همین الان تشکر کنم واقعا به سرگردانی، چون من خودم دو سه نفر از جوانان به خاطر همین سیپنا که آشنا شدن با سوسایتی ما که دنبال رزیدنسی میگشتن، من به دکتر سرگردانی معرفی کردم. همیشه بریم.
من رضا دانشور سرموز بیرون آفریقا.
اگه هستم فامیلین تافردی روانپزشک و برای ساعت کار میکنم و در مقطعی
همگی خیلی خوش آمدید و همینطور فکر کنم در زوم هم دکتر تو پرده نمیافتن، نه؟ دکتر اسکندری هستن که از تورنتو کانادا هستن و ایشون هم سهم بسیار بزرگی، زحمت بسیار بزرگی امسال کشتن همین زوم و همین ایشون تقریبا میشن سکرتری سیپنا بودن تو این سال گذشته. و قراره که بگم که سال پیش چیکار کردیم. بعد از ماه می همطور که میدونید ما هر سال چند تا برنامه زوم میذاریم که با اینا رو رکورد میکنیم و در کانال یوتیوب سیپنا هست، کسانی که میخوان ببینن. سال گذشته در 21 آگست دکتر سیمانیان برای ما صحبت کردن. همطور که میدونید دکتر سیمانیان خیلی واردن برای رئیس انجمن ارگانومی هستن در مورد ویلهم رایت و صحبت کردن در مورد نظریات فروید و ویلهم رایت و تفاوت با هم دارن و یک خیلی جلسه آموزنده‌ای بود برای همه ما. در 26 اکتبر دکتر شهریار باروتی که اینجا هستن یک سخنرانی به ایشون البته نگفتن، ایشون خلبان هم هستن، ایشون هم خلبانن و هم پزشک و یک صحبتی کردن در مورد why hospitals should fly که در مورد سیفتی ایشوز که در هواپیمایی پیش میره چطور و سیفتی هاسپیتال ها که چطور این دو میتونن از همدیگه یاد بگیرن. برای خیلی بحث جالب و اوریجینال و مفیدی بود. همینطور خانم دکتر مقبول حمیدی که الان در دوره گپشون بعد از ایشون DMP چند قبل از رزیدنتی خیلی فعالن و ایشون از الان فکر کنم بعداً یه مدتی میرسن در مورد فعالیت‌های اخیرشون هم میگن. ایشون در یک جلسه صحبت کردن در مورد APA فاندیشن به عنوان یکی از سایکیاتری امباسادور استودنت APA فاندیشن بودن و در این مورد صحبت کردن برای این. بعد یک چیزی که ما فکر کردیم که الان خیلی از این پیشگامان روانپزشکی در ایران ممکنه دیگه باید این صحبت ها رو یک جای داکیومنت داشته باشیم. در نتیجه تو 14 دسامبر خواستیم و از دکتر سیاسی و دکتر کرمانی اینا خاطراتشون و تعریفاشون رو با اون مطالعاتی که دکتر کرمانی خودشون یه مقالی هم نوشته بودن تاریخ روانپزشکی در ایران همونا اعلام کردن و دکتر سیاسی هم از سیپنا گفتن و تقریبا ما فهمیدیم که در ایران ما چطور یک بگیم دیوانه شد بیمار روانی، چطور یک دیوانه خونه شد بخش روانی و این زحمت‌های بسیار زیاد کشتن. دکتر شامی خودشون اینجا هستن، کار آسانی نبود و اینا کردن و همه گفتگوهای ایشون و دکترای دیگه که خاطرات خودشون رو گفتن و حساب کردن همه اینا رکورد شده و 2 مرتبه در یوتیوب کانال ما هست و اینم یک داکیومنتری جالبی میشه در مورد اورال هیستوری، میتونه بگیم اورال هیستوری جالبی میشه در مورد تاریخ روانپزشکی در ایران که سال بعد کردیم. هر سال سیپنا چند برنامه فرهنگی هم داشت. ما دنبال این برنامه بودیم که متاسفانه از ماه جنوری که همه ما بودیم که همه در واقع منتظر بودیم، همه هم عزادار و هم عصبانی و هم ناراحت و همه اینا کنار هم پیش رفتیم. در نتیجه اون برنامه ها موکول شد و همه از ما پرسیدن که بعد از جنوری چرا هیچ برنامه‌ای نداشتیم، برای اینکه همه ما منتظر بودیم ببینیم چی میشه. ولی دو کاری که از نظر سیپنا ما کار دیگه که از نظر این اکزیکتیو کمیته ما انجام دادیم، یکی در همون حوالی ما سیپنا به عنوان جزئی از یاما ایرانیان امریکن مدیکال اسوسییشن و هم اعتراضی کردیم برای حمله به مراکز درمانی و پرسنل درمانی و بیماران در ایران که این رفت و همینطور در تاریخ 3 فوریه سیپنا با امضای دکتر نجفی خودشون یک نامه مفصلی هم سیپنا در مرتبه همین مسئله رو امفسایز کرد که این قابل قبول نیست که به مراکز درمانی به هر دلیلی یا به هر صورتی حمله بشه و پرسنل درمانی سیف نباشن. به هر حال اینم یک چیزی بود که حتی رفت و در بعضی از این کاکوس های APM انجام شد و یکی از نتایج اون این بود که یک کاکوس گلوبال منتال هلت داره APA و دکتر فلمینگ که اونا به ما اپروچ کردن و از ما خواستن که اینا تونن در مورد منتال هلت ایرانیا صحبت میکنن و اطلاعات خواستن و یک جلسه زومی بین خانم میر هاشمی و دکتر اسکندری که از کانادا و هنوز با طریق تلهلت مریض در ایران میبینن با دکتر فلمینگ یک جلسه ای داشتن و این که گزارششون رو بعداً خواهند داد. یا میخواید همین حالا در مورد اون گزارش بگید که در ضمن خانم فاطمه میر هاشمی خودشون سیپنا رو پیدا کردن و خیلی خوشحال شدیم که الان انترن سیپنا هستن، اینترنشیپشون اینجا میکنن. ایشون سایکولوژی خوندن و الان که میخوان اپلای کنن برای یک پی اچ دی پروگرام برای سایکولوژی و روی تروما خیلی کار میکنن که الان صحبت خواهیم کرد و خیلی فعاله، یعنی خیلی سیپنا رو با هم یعنی الان تمام سوشال میدیا دستشون خواهد بود و بعد نظرات خوششون خواهم داد. ولی کم کم الان میخواین در مورد اون گلوبال منتال هلت فقط بگید کمی یکم آشنا بشن که صحبتتون.
May I ask whether she can speak both language, Farsi and English, or you prefer English?
You know, you can speak English, everyone can understand you.
هم فارسی بلدم هم انگلیسی ولی خب So during our insightful conversation with Dr. Fleming, he had two main questions to ask Dr. Iskandar and I. The first, what is the current mental state of Iranians, both inside Iran and outside Iran? And Dr. Iskandar began by saying that it's great that you classified it into two, the Iranians in diaspora and the Iranians inside, because they have two currently different struggles as of now. Dr. Iskandari works with both Iranians inside and outside. And in his experience, he said that the grief, PTSD, anxiety, and stress is common in both populations, but excessively so in the diaspora. برای ایرانیایی که خارج از ایران زندگی میکنن، این استرس جنگ و all the conflict in Iran بیشتر است. And this might be surprising, but it actually matches up with some of the research we see in sociopolitical conflicts wherein diasporas are actually more affected, especially considering the communication blackouts, the internet blockages, and mainly the uncertainty that we feel as Iranians in the diaspora, where we still feel connected to our homeland, but we do feel helpless to stop anything. And so Dr. Fleming asked, how can psychiatrists of non-Iranian descent, how can the APA in particular help? And our answer was to uplift Iranian voices, especially Iranian mental health care providers. The most important thing is culturally informed mental health, especially in this case, trauma-informed and culturally. And it's very important to prioritize that when treating Iranian mental health patients, because their struggles are inherently woven with their Iranian identities. And it's important to recognize that when treating these patients. And uplifting Iranian voices, having collaborations between the APA, the Global Mental Health Office,
And organizations like SIPNA is incredibly important in that respect. We also talked a little bit about my research with Dr. Eskandari, which is actually on the impact of Iran's current socio-political situation on the mental health of Iranians. Essentially, what is currently happening, what is the trauma, stress, depression, and anxiety that we feel right now, and what are the protective and risk factors that need to be for moderate these outcomes. And Dr. Fleming actually introduced us to Dr. Kenneth Park, who is actually an APA member, and he works with the University of Toronto on these topics as well. So that's an emerging point of discussion.
Thank you very much. And one more thing that we did was bylaws, as you know, that it was the time to have a renewal of bylaws. Dr. Shafa, when he was president, and it was years that they are working on renewing the bylaws. There was a big committee working on it. But whatever we did, finally, with the help of Dr. Eskandari and especially Dr. Pahlavan and Dr. Jalili, it is in Canada. He's not on Zoom now, no? So we all were able to summarize bylaw and make it more simple for people to come and join and work in SIPNA. So I think they have sent the bylaw to all of your emails. Whoever is a member of SIPNA probably have received it. I don't know if you have studied or not, but in a nutshell, we have board of trustees, we have a board of directors or executive committee, and we have different types of memberships. That's whatever this bylaw says. Board of trustees are made of ex-presidents, so a number of ex-presidents are there. Board of trustees oversees the functions of the society and also will handle the elections that happens every 2 years. All other functions are being handled by executive committee. Board of directors are being elected by members. Those who want to be candidate, they every 2 years, they put their names by certain dates to the board of trustee. Board of trustee will announce them to everyone, and the election can be just like APA elections by online or other ways, that and nobody will know that who's voting for who. And then it will be, the names will be mentioned before the annual meeting in 2 years. Today, because it's intermediary and there are only 5 people have been candidated, although there were several, Dr. Najafi, the Board of Trustees, they sent several announcement to people who wants to be candidate. So far, only 5, and there are 5 for Board of Directors, so we will give the names. And we will ask for your vote just to make it official. So then the board of directors is made of president, president-elect or vice president, secretary, treasurer, and the 5th person, or whatever we call it, past president, or if the past president doesn't want to be, choose the 5th person in order just to have 5 people when they want to make their votes. And in the bylaw, they have some put that each person, each position, what responsibilities they have. And we have memberships. According to SIPNA, every psychiatrist practicing in North of America is member of SIPNA. So that's it. And we have associate members that are psychologists or mental health professionals, psychiatric nurse practitioners. They can be there. Also, we have for psychiatry residents, for who can vote, who cannot vote. They are all mentioned in that bylaw. So this is the bylaw that Dr. Jalili and Dr. Pahlavan and they have worked on. Dr. Pahlavan also was the one that worked mainly on the original version of SIPNA bylaw. So I don't know if you have read it or not. It's in your mailboxes. But today, actually, we should officially ask that if anyone who has read this bylaw has any question about any item of that. Or if you have any concerns about the nutshell that I said.
You wanna ask how many we have read and have, given the order or not?
Pardon me?
You know, you wanna ask how many people have read, how many people who are here?
Okay, how many of you have read bylaws that have been sent to you?
I didn't receive that.
Okay. So,
Doctor, we had almost 39% that have voted for the bylaw.
who said that?
Dr. Iskandar.
Okay, so far 39%, 39 people, sorry, 39 people online have given a yes to this new bylaw. Any of people who are here are part of that 39?
Yes. Yeah.
Okay. I'm not sure if I was one of those or not, but I
Actually voted online, or they have sent text to us or emailed us that we received we received their opinion regarding the bylaw. Yes, approval. Yes.
Quorum, that's.
So if 39 people from SIPNA have said yes, apparently it means that the bylaw is in effect now, correct?
That's correct. Yes.
Okay, so let's, those are in favor, let's just say aye.
Aye.
Okay. And nay,
Opposed? No.
approved, yeah, okay. So from this moment on, we go with the new bylaw. Dr. Iskandar, so you got that, yeah?
Congratulations. That's all. That's what I can say for all the efforts that the committee had. All individuals, all of the colleagues. I really appreciate their efforts, their supports. We can make this bylaw updated for a long time. We were waiting for this kid to be born. Congratulations all.
So so this was another thing that we, Board of Executive Committee, we were working hard on it, and especially Dr. Iskandari and Dr. Pahlawan, they wanted that, and Dr. Mirabi, they wanted that this goes in effect as soon as possible. So you got whatever you want, so that's good. So now the next thing is, what are our or if you want, we can go over the names of the elections and then we go over the programs that we have for next year. So as we said, there are 5 positions for executive committee, and there have been only 5 candidates for each position. So I will say the names, and if anyone have any, because nobody else has been candidated through those emails themselves. By this, I have been president-elect for next 2 years. So now I will be president according to old bylaw, and by new law, if you agree, so I will be president. I'm a candidate for it for next 2 years. Thank you. As a president-elect, or let's call it vice president or president-elect, we both terms in the bylaw is Dr. Mehran Motamed. Would you stand up?
Bravo. Ask him to see if accept the position, and then we give him the vote.
Will you accept
Are
the
you ready?
position?
Yes, I want to express my deepest gratitude to our esteemed psychiatrists who happen to be board of trustees and also executive members for the trust they put in me, and I hope with their continued help and mentorship to be able to help SIPNA to achieve its goals. Yes, it's my honor to accept, and thank you very much.
Next is our, let's call it past president, will be Dr. Najafi, and also I myself should thank Dr. Najafi, Dr. Shami, that they helped me a lot in the last minute decisions, Dr. CRC, Dr. Pahlawan. So I learned from all of you. So Dr. Najafi, you agree to, for next 2 years, still be in the executive committee?
Yes.
And Dr. Iskandari will be our secretary. So Dr. Iskandari.
Yes, I will be glad to.
Okay. Okay, and the last but not the least is Dr. Shami, for years has been the treasurer of SIPNA. So will you accept to be again treasurer of SIPNA for this term?
For another 2 years, and then you decide. Because I was given this position, as Dr. Siasi said, lifetime. I didn't accept it because I want to do something else in my life. But again, as long as you want, I'd be glad to help you. And when I have a chance to come and talk to everybody as a treasurer, I have some points to make about that.
Okay. So now we are done with like another part of the agenda of this of today.
Dr. Siasi wanted to welcome and also give some speech short.
Is he on?
If Dr. Iskandari could get Dr. Siasi, who could not attend, but he wants to present some.
That will be great.
If he could be connected by Dr. Iskandari, that would be great.
Dr. Iskandari, so let us know as soon as he gets online.
Okay, sure.
Okay. So, and what we want to do for the coming year. Again, we have tentatively, we don't have exact dates, but again, we have like planned for 3 lectures or programs for next 6 months. And after that, we come up with another plans. So whatever we have first is that as you know, those of you are in addiction, and in Chicagoland, Dr. Ruin Rafayan has a big practice in addiction as a medical director of one of my main addiction centers in Chicagoland. And he agreed to talk to us about the updates on ASAM, and he will tell us more about it. And also Dr. Hamid Ikhtiyari, who works on TMS on for addiction, agreed that be like a co-presenter with Dr. Ruin in one of the Zoom programs that we have. Dr. Ruin, would you tell us what's?
Sure. First of all,
so you can come here. No, please.
I'm not trying to dig me. Wonderful to be here, and thank you for the invitation. We're looking forward to spending more time together. Some discussions I had with Dr. Giliano, it's like, let's move beyond just meeting once a year here at APA. We can remain connected and have some topics as you've done in the past. It can be helpful. So brainstorming as of what to present. I thought, ASAM new edition is updated of the criteria. Some of us do addiction work, some of us don't, but it's a good idea to be familiar what the new updates are, especially for adolescents. I heard some our colleagues here do child and adolescent work. So knowing those updates, I think will be beneficial because it continues to evolve. We can actually schedule more of these meetings. I also do research and talk about what's in the horizon, what's in the pipeline, and where is the pharmaceutical research going.
Thank you very much. So we look forward to
Apologies. Thank you very much for saying that. Thank you. You have a wonderful meeting.
Okay. دکتر سیاسی میخوان در مورد سیپنا اولین سالی هستند که دکتر سیاسی تو این میتینگ نیستن.
میخواید یه چند لحظه تلفنی الان میشنوید صداشونو؟
ببینیم.
بله یه لحظه گوشی جناب دکتر میشنون صدای شما رو. بله الان میشنون.
Can someone use it in a way that هیپرتنسی
بله بفرمایید جناب دکتر.
تلفنشون
رو تلفن تصویر نیست.
آره اوکی. صداشو من ضبط کردم.
دکتر سیاسی ادامه بدید بفرمایید.
سلام آقای دکتر سیاسی، سلام علیکم. خیلی مقدم برای شرکت در جلسه متاسفانه بعد از 2 سال مستمر که من در جلسه شرکت کردم امکان میگه از لحاظ سلامت به طور کلی امکان شرکت نبود. به هر حال امیدوارم که همیشه همگی با هم باشید، دست به دست هم بدید و این سیستم رو زنده نگه دارید، برای اینکه بالاخره روانپزشکای خارج از ایران نیاز دارن که با هم تماس داشته باشن، نیاز دارن که از همدیگه حمایت کنن و امیدوارم که این ادامه پیدا کنه. با عرض خداحافظی با تشکر. خیلی ممنون آقای دکتر سیاسی، جاتون خیلی خالیه اینجا. من خیلی دلم میخواست اونجا باشیم ولی خب بگم که حاصل که پیر شدی از نیکده بیرون صبح واقعی یواش یواش همون کاری که دکتر میرابی گفت از رفتن تند بالا و پایین به اصاب و بعد حالا دیگه به منزل رسیدی افتادیم. این تاثیر همیشه هست. بله.
متشکرم دکتر سیاسی که شرکت کردید در این جلسه ای که شما در سال 1982 بنیان گذاشتید.
بله مرتب به هر سال شرکت کردید.
این پرچمی که شما افروختید پایدار بمونه برای همیشه.
برای همیشه. قربون شما و خدا حافظ و همگی.
خدا حافظ.
مرسی جناب دکتر.
کنم پیام دکتر سیاسی رو اگر نمیدونم چقدر شنیدید، همون بود که از خواستن که با هم نزدیک باشیم، با هم دوست باشیم و این سیپنا رو نگه داریم و به پیش ببریم. این پیامشون. بعد از یک صحبت دیگه ای که در سال آینده تصمیم گرفتیم که داشته باشیم در مورد تراماس و میدونیم که امسال با چیزایی که همونطور گفتیم با حادثه‌ای که در ایران میره پیش میره و صلاح شده یک there is a new topic that we call it transgenerational trauma or intergenerational trauma, and we know that this is a topic that has been studied in some populations. And whatever nowadays we think that people that they haven't been in a generation that have been under trauma, still they feel it. So they think maybe it goes through epigenetics. And that will be by me and by Khanme Mir Hashemi. So and she will give us a little bit more introductory about what the talk will be.
من فقط اینو باید به پروژکتور بود.
Do I need to connect or this?
What is it? Okay, that's it. Yeah, that's it. Continue.
Okay.
خانم هاشمی این دیوایس که به اسم سیپنا هست رو میوت کنید فکر کنم اینجوری بهتر باشه اکونش با همین دیوایس که الان کار میکنه. هنوز میوت هستید خانم امیر هاشمی شما. الان صدای ما رو باید داشته باشید. الان فکر کنم درست شد. بله الان اکو نمیشه.
تاپیک امسال transgenerational trauma هست و من میتونم یه دیسکانکت کنم بهتر باشه. نمیدونم چرا هنوز صداش
One more time.
We always have this problem when we log in.
میوت اینو بعد Yeah. This year's topic is transgenerational trauma, which is essentially the idea that trauma can be inherited.
For just 2 minutes is okay, Dave.
اصلا میوته
ما صدا رو نداریم. We don't hear any voice. نمیدونم یکی از این سیستما رو میخواید
میشنوید صدا رو؟
What happens? Let's try one more time.
Like still have your Zoom, right? Yeah, I still have
You
this.
wanna try that?
Just disconnect this. Probably.
Try that.
Yeah.
الان اوکی بله.
This is going, no, this
Yes. Yes.
Okay, yeah, should have done that a long time ago.
That's okay.
Okay. So when we think about what we inherit across generations, a lot of the times we think about how we inherit our DNA. We inherit our cultures, we inherit traditions that are passed on from our families. And now there's an emerging area of psychology called transgenerational trauma that talks about how we actually inherit legacies of our family's burdens as well. Usually and traditionally in the DSM, psychology and this field essentially believes that trauma is an individual experience, right? Understandings of the traditional definitions say that it's exposure to events that are either like threats of death or sexual violence or different traumatic exposures that happen to one individual person. And this emerging field says that the trauma that happens to an individual person, whether in this case instances of war, can actually pass down from the parents to the child and even to second and third generations through mechanisms of parenting practices, modeling the effects of trauma, and even biological mechanisms through epigenetics. Now, this is just a preview of the actual presentation that will be happening online in July. But essentially, what we want to understand is why do these generational patterns and cycles of trauma happen? How can we prevent it? And how can we understand it within Iranian communities? The difficulties that the Iranian community has been facing are not recent. The sociopolitical issues in Iran and the pressures that have been on Iranians, both within Iran and outside, are indescribable. And they've had tremendous mental health effects, as Dr. Iskandari said, in Iranians right now. And this has affected generations, newer generations like us, as well as generations that are to come. And so the important point about understanding transgenerational trauma is how do we stop these cycles of trauma from being inherited? And how do we stop the mental health effects that we are currently feeling as Iranians from passing on to our children, our grandchildren, and so on and so forth. And so that is what our presentation will be about. And apologies for all that.
Thank you very much.
Thank you.
And also, as I said, I practice in Chicagoland. So in Chicagoland, there is a big Jewish community that they are, either their parents or they were survivors of Holocaust, or they came here when they were children. So for me, that I've been practicing there, like maybe when I started 2020, for me it was a little strange that these people that they were born after their parents immigrated to America, and they are raising. Why still they talk about Holocaust and effects? It affected their parents, even their parents were kids. So now they're adults and affected. So, and as you said, it's emerging. This transgenerational trauma has been studied in, as we said, Holocaust survivals, and also in indigenous American, whatever we call them, American Indians here and in Canada. So these are two populations that mostly these studies have been there, and the topic is on, you will hear it. Whatever Mir Hashemi wants to start and doing the research in Canada, wants to, because there is no such a study in, like let's call it, in Middle Eastern people. And we know that in Middle East, people have gone through traumas, if not for centuries, at least we know in 20th century, different population, different races, they have gone through a lot of trauma there, including people in our country. But there is not such a study. So they want to start with this global mental health that they approached us, and with help of we are seeing that if University of Ottawa will support to do some research, that some preliminary research to get some data. And so she's very active to start this research. And I just told her that, you start, you plan, you go ahead. And if University of Ottawa doesn't support the Iranian organizations or Iranian communities, somehow will support your research to get some data from it. So I think that this is a good step that SIPNA also be involved in the new thing that in the coming year. And the last thing that we have talked about, we used to up to 2024. One of these things that we all loved in SIPNA was watching a movie and talked about that from different psychodynamic aspects or cultural aspects. And we watched, and you remember, a number of Iranian movies that are on Zoom that we talked about. So this year we have chosen a movie جاده خاکی by پناه پناهی, the son of جعفر پناهی, one of his first movies. And it is very dynamic related to family relations and to immigration and other issues that all of us more or less are very familiar with. So we thought that maybe closer to holidays, that will be one thing that we all watch it and talk about. So far we have talked about, we have arranged 3 talks, is about addiction, about transgenerational trauma, and about this movie. And you will receive the announcement by Dr. Iskandari through emails. And Amir Hashemi has a new intern. She will work a lot on social medias that hopefully we will be more in touch, and we will see you on Zoom. Or if you cannot be attended later on, you can see them on a YouTube channel, SIPNA site, and watch those presentations. The other thing that I want to say, all people in SIPNA, we for years, one of our main goals was to help younger people that they come here, they want to get to the psychiatry residency or psychology programs or whatever to be help for them. So we want to continue that. So that's, I think that it's good that we all help, and even each year, if one of us goes to a program, we all get happy, just like Dr. Baruti that this year is going, and we are very happy for him. So anyone, if you know any person that wants to have any presentation that you think, as I said, SIPNA is a society, allied society with APA. So if you put on your resume that I had such a presentation in such a program on your resume, it will make your resume a little bit more, let's call it shining. So it's good. So any of you, if you want, or if you want, we are happy, and we will arrange that. And that's whatever help we can do for young people, we will do to get to their goals wherever they want. So we should all help that. And also, if you think of any other presentation, let us know. We will go. So, for example, Dr. Motamed asked Dr. Baimi, to the brilliant psychiatrist in the Iranian community, and if he wants to have a talk for us, I remember years ago he had one. And again, if he wants to have, that will be, or if he agrees to have, not once, agrees to have for us, that will be an honor, so we can arrange that too. So whatever you think about, we are happy to hear the suggestions and move on with it. So I think this was my report, and now I think we should open the forum to questions and suggestions. Oh, Dr. Shami, sorry, your report.
If you're ready for it, I am ready. Maybe. That's part of the presentation. I'm happy that all of the seats taken, except 2, which is reserved. We were very surprised and happy to have you all here. We didn't know up to 2 days ago that we are going to have enough people to come in to this very important meeting for SIPNA. And I'm glad. I'm really happy because of the effort.
Where the member informed in the past, we get a letter or something,
Nobody sent it.
Dr. Iskandari has sent emails to everybody.
Everything has been done in our way, which is older way. Let's get the younger generation to come in to do it in a new way, which is very difficult for us. The previous younger generation who came in and left, they were trying to get rid of us, and they disappeared. Now we are going to get them back together, and we gradually get up. But that gradual could be 10 years, 20 years, depending on how young you are and how much you want to put into this community and very exciting event that we are carrying from the generation that is still living, Dr. Hirasias. And thank you for his really beginning of this group. And I am one of those people who was available at the time, and several other you, some of them that are not here. We really want to continue to grow with new generation and also get this idea that as we become stronger, we get bigger, we become stronger. That's what we are hoping. Now, my really position as a treasury secretary, as well as treasury secretary, was given with pride to Dr. Skandari, and I gave him executive secretary, which on this flag, I can show you, but give me one of those, please. Yeah. We are really appreciating Dr. Skandari, who is helping us with the media and also all of the activities that has to do with the Zoom. This is a gift from SIPNA to him.
Oh, thank you. I appreciate it.
For you. Dr. Mohammad Reza Eskandari, MD, MACP, RP. He has given this for me, given permission to put it after his name. Executive, I put it before his name, Executive Secretary of SIPNA, in recognition of his commitment and outstanding services towards the advancement of SIPNA goals. With the www.sipna.net logo here from SIPNA Executive Committee members, which are all present here. Can you raise your hand? How many of you are the Executive Committee members? 1, 2, 3, 4, 5. So I myself 6. That is really what keeps the SIPNA going. And we want every one of you to continue as long as you want, as long as you can, to be able to keep this flag still up there with among other flags, to be able to survive and become somewhat effective in advancement of mental health in a community of Iranian or Iranian interests with background that we have really other people to join us. This would be given to someone who can see Dr. Skandari in Canada, who is sitting here, and would accept this really responsibility to give it to him. Before I give you a little bit more information about my role as the treasurer of the SIPNA, I would like to give you another, show you another tablet that's made for Dr. Mortaza Najafi, our now I can tell past president, as of about an hour ago. And this has been made with his name, Mortaza Najafi, MD, DFAPA, which means the Diplomate of Fellow APA.
Distinguished.
Distinguished life member of APA. That is what the meaning of DFAPA is. President of SIPNA to 2024 to 26, in recognition of appreciation of your outstanding leadership, dedication, and services for advancement of mental health. SIPNA, that's from the SIPNA committee. Thank you very much. من چند نکته رو به شما یادآوری میکنم که واقعا کاری که ما میکنیم باید با عشق و علاقه باشه، وگرنه به زحمتش نمیارزه. و من این رو احساس میکنم که به دست آوردم. شما اطلاعی دارید رو هم بگید چی کار رو باید کرد. فقط یادآوری کنید که چی کارا نباید کرد. اونایی که باید کرد که انجام بدید، اونایی که نباید کرد رو بگید من با کمال میل گوش بکنم. دکتر احمد جلیلی در کانادا هستن، ایشون واقعا یکی از دوستان و همکاران عزیز ما هستن، در ارتباط با روانپزشکای ایرانی هستن مستقیما، خودشون هم مسئولیتی داشتن و ما باید امیدوار باشیم که یه روزی دور هم جمع بشیم و بتونیم این واقعا پیس ریلیشنشیپ رو با روانپزشکای ایران داشته باشیم. چرا نه؟ و امید داشته باشیم که بعضی های ما که هنوز میتونیم ارتباط برقرار کنیم، ترانزیشن بریم و بیایم و بعدم برعکسش اتفاق بیفته. اگر این اتفاق بیفته ما واقعا خوشحال هستیم که تونستیم روان پزشکی رو به واقعا موقعیت زمان ادامه بدیم و بزرگش کنیم. من یادم هست بعد شدی شما خیلی یادتون نیست موقعی که در بیمارستان روزبه من استاج میدیدم به عنوان دانشجوی سال سوم، به خاطر اینکه هیچ چیزی حاضر نبود برای روانپزشکی و جای خالی بود، انترن نداشتن. من توی تابلو اعلانات دانشگاه پزشکی با یکی از دوستان دکتر سراچی اورنگ راه میرفتیم، دیدیم که دو تا تابلو اونجاست، یکی نوشته بیمارستان روزبه احتیاج به اکستند داره، یکی هم نوشته بود که دکتر مفید در آزمایشگاه احتیاج به اکستند داره. هر دوش خالی بود جا. اون با کرم و انگل سر کار داشت، این با انسانی که احتیاج به کمک داشت سر کار داشت. دکتر یادش بخیر، البته در لس آنجلس ما هم دیگه نمی‌بینیم، سراچه اورنگ سید با شیر قاطی بود، نزدیک هم بود، ما با هم دوست بودیم، خیلی نزدیک، ولی در داستان نمی‌بینم دیگه. اون گفت من میرم اونجا، میرم برای دکتر مفید. گفتم چرا؟ گفت من حوصله سرکله زدن با آدم‌ها زیاد ندارم، میخوام برم تو آزمایشگاه کار کنم. تو برو برای با کرمان کار بکن، من میخوام برم با انسان‌ها کار کنم. برای من انسان مهم بود که بشناسم و جایی رفتم که هیچ شناسایی ازش نبود. بیمارستان روزبه چسبیده به بیمارستان دیگه، بهش میگفتم تیمارستان. امروز یکی بود تیمار بیمارستان چیه؟ ما اگه راجع به تیمارستان صحبت کنم بعدشون نمیاد دیگران. گفتم تیمار برای حیوانات بود، انسانی که بیمار روانی هم بود جزو همونا استفاده شدن براش. ولی ما وظیفمونه که واقعا آموزش بدیم که بیمار روانی هم مثل بیمار جسمی مورد احترامه و بعد بهش کمک بشه و این کمک رو ما فراهم میکنیم. امیدواریم آیندگان هم این کار رو بتونن بکنن. بین کسانی که ما واقعا نیاز داریم دوستان منتال هلت رو داریم. ما باید اکسپند بکنیم، فقط روانپزشک نیست، روانشناس. تعداد زیادی روانشناس هستن ما نمیشناسیمشون ولی میتونن واقعا کمک کنن. موقعی که من وارد شدم روانشناس وجود نداشت. اینا رو شاید بعضی از شما باورتون نمیشه. روانشناس به وجود اومد به خاطر اینکه کمبود روانپزشک بود و روانشناسا کم کم اجازه گرفتن که پی‌اچ‌دی بگیرن و مستقل کار بکنن در یه زمانی زیر نظر روانپزشک. حالا مستقل هستن، خیلی‌هاشون روانپزشک گذاشتن کنار مگر مجبور بشن، مگر مریض بیاد و بگه منم قبل روانپزشک کار کردم ولی احتیاج به شما دارم. یا خیلی هاشون هم امروزه خوشبختانه با ما کار میکنن. اون چیزی که تحوله باید به زبان آوردن، پذیرفتش. خانم دکتری اینجا هستن که به زبان فارسی آشنایی ندارن ولی یک زمینه داشتن که اومدن این جلسه و ایشون رو اگر بخواید من میگم یه چند کلمه‌ای راجع به تخصص خودشون بگن. دکتر نجفی در گروهشون چند سال پیش به من گفتن از RN practitioner psychiatry کمک بگیرن و تعداد زیادی هم دارن. خوشحالم. من هم الان یکی رو تربیت کردم 2 سال با من کار میکنه و الان کاملا مثل روانپزشک نسخه می‌نویسه. مریضای فالوآپ می‌بینید ولی من مریض در لیست اول می‌بینم، تشخیصش میدم، به خصوص اگر مدیکال لیگال باشه که psychiatric problem is the secondary, is not primary, is handling the patients very well and I'm very happy with that. And this really occasion, Sophia Moran is here, is going to tell you a little bit about her activities, and that is the nurse practitioner with the psychiatric education. Next year here, or we are gonna be in New York, hopefully, we are gonna have more people coming and especially expand it to the others groups of mental health professionals. What else do you want? I wanted to talk about nothing else. My responsibility as treasurer has been fulfilled to me as a responsibility and a pleasure, because what Dr. Vaughan, our past president, actually Najafi, gave me was some money that was in the book with a lot of problem. He was able to transfer that money to me. And I have promised myself, I allow this money to expand to the extent to be used and not being abused until I give my position to somebody else. Hopefully, somebody from this crowd wants to voluntarily accept my position. I'd be glad to transfer this. Treasurer of SIPNA.net. If anybody wants to accept it, please raise your hand. I give you a checkbook which has the amount that Dr. Najafi gave me exactly, because contributions haven't been
10 years ago.
come.
10 years ago.
Huh?
10 years ago.
10 years ago. I have a contribution to make sure that his money that was given to me is not depleted, even though we had some expenses.
دکتر شمی ارزشش اومده پایین مانی اون دلار اون زمان خیلی زیاد پول
I
بود.
give you the same amount. I give you the same amount, regardless of the devaluation of the dollar. But don't forget, the valuation of the dollar is appreciation in real. And that is something that is out of my scope of even thinking. But again, I think that, to help a person who is disabled is a job of the government. The people who are not going to be disabled and they are in the verge of health to disability is our job. If somebody is psychotic, but we can control them and they become somebody in life is our job. If somebody is manic depressive, I wrote my thesis when I graduated from medical school, manic depression. And my thesis is still, the booklet that I have is still indicated to treat the manic depression with lithium carbonate. It still is the best medication. That lithium carbonate was studied in the Lafayette Clinic when I was a resident. So that's a contribution. Every one of us has done the contribution. I think that's summarize what I have done and what I would be able to do, and also promise to, if I'm still healthy and active, by 2028, I would transfer, not voluntarily, by force, to somebody else.
Forcibly.
If somebody wants to take it now, that's fine. That would be at that time. I think that before I finish, I want to talk to Dr. Shahriar Baruti. And I want to say something about you, Dr. Baruti. Welcome to SIPNA. You are a psychiatrist, right? Yeah. Are you in California or not?
Right now in California.
You are. Do you know Mr. Baruti, who is in financial or is an attorney and is very popular, but is not in mental health? Do you know him?
No, but I heard about it.
You have heard. I had not heard about you, but I had heard about that Baruti. I want to talk in this group as a joke, but if you want to repeat it somewhere else, that's fine. It's not going to be a bad joke. When last year we were going to have a group meeting, where was it? In Los Angeles. I don't forget. I had a company, just one that provided us with everything, who agreed to come in for a medication to be presented and have a group. The last minute, when we had invited everybody in a restaurant downtown Los Angeles with a vendor and that just prepared everything, they called me, they said, our company is not able to do this. I said, what? Your company is not going to go through this obligation? We have invited people, everybody's invited, a restaurant. That was, at that time in my office, I remember it was afternoon, I had my lunch already, otherwise I would have fell down on the floor. So this is a bad news. One of the company's representative, drug rep, was there with a friend. They said, what happened to that Shani? My secretary said he's very upset. You can't go to their room. They said, let's go, let us go to see what happened to him. They were scared that something happened. They opened the door, they came in. I said, the last minute somebody canceled. Well, what are you doing in here? You're a drug representative from another company? I said, what happened? I said, they canceled. I said, we take over. We take over. I said, wow, you want to take over? You've got to invite some people by tomorrow in a restaurant, find a place. Can you find a place in LA? Be a very busy place. They said, we know a couple of, they called one of the nicest restaurants. How many of you were there? You know what the restaurant was? Beautiful restaurant. They opened a really guest room for everybody, up to 30 people, and they paid from everything that they were charging, and we were really happy that we were able to have that. This was very exceptional. And then among the people who signed up, this was Mr. Baruti. They were supposed, not like here, we were not worried about, who is going to take care of. But we were told that we want to have the name, everybody coming should be connected to mental health. I called Mr. Baruti. Did I know that we have a friend of Mr. Baruti here? So, Mr. Baruti, are you a psychiatrist? He said, no. Are you a psychologist? No. Are you related to mental health? No. Why are you signing up to come to our meeting? You got to know that this is just for those specialists. They said, I don't know, somebody wrote my name, they said they are going to give free lunch, and I am coming for free lunch. I'm sorry, I have to cross out your name. Sorry about Dr. Baruti. If it was your friend or family, tell him that when you want to sign up, you better know that you are accepted. So I didn't want Mr. Baruti to come in, but I'm glad that you came in. So I think that it's a pleasure to really serve you as well as other people. As a treasurer, I don't have any really document to show you about the money that we spend, but I can assure you that the money is in the bank and we have some expenses that we pay every month. And if you want to contribute, please give me a check. I do have one check. I wanted to thank Dr. Mortaza Najafi for the contribution. Should I say the amount or no?
برای دیگران که چیز کنن بعد نیست بگیم.
Now, I have a check of 2024 from Mahshid Asadi, MD. It was not put in the bank because my failure, I lost it, I recently found it. I had another one for Dr. Tehrani, who is Abul Ghasim Tehrani, $100, was not put in the bank because of my fault, but he was able to change the date, and I'm going to put it in the bank. I have had another. I can tell you how good treasurer I am. Dr. Mortaza Najafi has given $500. Thank you very much.
You're welcome.
And this is the second $500, by the way. There was another one sent to me, and I gave him the check of $500 that could not be put in the bank. So now, if anybody wants to do a contribution, please, or get the bank account and you transfer the money directly to the bank account. If you like, I have the bank
Account at Zelle?
statement here. Pardon?
Is your account at Zelle?
Unfortunately, I don't have anything, unless you wanna give me your credit card, I get the picture. And then, back and forth, tell me how much I can charge, I can charge it.
If you have a bank account, you can.
We have a bank account, I give you the bank account, a card from the bank, and then.
By your name,
No, it's the SIPNA name.
SIPNA.
SIPNA name, First Citizen Bank. I can give you this one, the actually bank account, everything is written here, and then you can transfer the money, whatever you want, contribution with the First Citizen.
That, will be a place in our website that the people can donate online, is also in every other organization, if you want to donate, that would make it much easier.
Yeah.
Dr. Mohammed, I think that will be your job to arrange that.
Yeah, we have online portal for the payments
Contact
through the
them and
PayPal.
we will let you know, yeah.
By the permission from, SIPNA.
You have.
I think that when we are together, we are excited, that is the time to get the contribution. When we go to our work, it's gonna be difficult to get your attention back.
Phone number, if people have your phone number, they can serve you, everybody has.
But it's by SIPNA, it's not by his name.
Oh, I see.
It's by SIPNA.
So then that actually works out with the distribution. I will be in touch with Dr. Stanley, just to.
Yeah, we have a PayPal account as well. People can pay through the PayPal, through the website.
Usually we can.
Because there will be individual, the one who on
The business can also.
then he has to open a business account, so maybe he doesn't have.
Oh, okay.
Anybody has a check or credit card that can accept it this year, we are not ready for that. I used to have a ready way to get a credit card, but if you want, I can give you the First Citizen Bank's account number, and you can send it later on, if you like. And that would be contribution to real advancement of a lot of things that we can do, and there is some expenses involved.
So we can ask you to make sure that Dr. Shani will not do this time, okay?
We're gonna open up a Sal account.
I give you.
PayPal even, that would make life easier.
It doesn't need a phone number, it just needs to know the cell.
Yeah, literally with PayPal and stuff.
That's it.
Dr.
Dr. Terani made another check, and that is appreciated. I gave him the old check of 2024. Now, I think that I'd like to ask Sophia Moran.
Yeah, that you will be,
Assisting.
make sure that our money will go to the bank.
We'll set up a.
She's gonna be assisting me to make sure that everything is organized for the next year.
So wanna ask to tell us about.
Dr.
how
Shami.
their psychiatric practitioner.
Absolutely, thank you guys.
دکتر شمی صدای من داری؟ الو صدای منو داری جناب دکتر؟
Thank you. I'm a psychiatric nurse practitioner after being a ICU nurse for 15 years. I was ICU trauma for Loma Linda University Hospital. During COVID, all the, mental health disparities drove me to go into mental health. As nurses, we're terrified of mental health, right? Doctors are terrified of mental health. So only a small percentage of psychiatrists, as you guys know, oversee our mental health throughout the world, not just the United States, but all over the world. And so there's a huge gap in care when it comes to providing services for our patients, especially our underserved populations or patients that have hard access to mental health care. So as a psychiatric mental health nurse practitioner, I serve the 1% of the population of nurses that has gone into the field in the United States. And so, thank you. Thank you. I work with a lot of patients in Southern US, which are underserved communities, Northern California. I also do TMS clinic in San Bernardino for veterans a lot of veterans, a lot of underserved populations, Medicare, Medicaid patients. So as nurse practitioners, we close the gap in care, right? Psychiatrists do the hard work, manage the psychiatric disorders, intense stuff like schizophrenia. As a nurse practitioner, I focus on adolescents, children, toddlers, throughout the lifespan, just supplementing the gaps, and then I refer out as needed. I do a lot of depressions and anxieties. I'm finishing my doctorate at Johns Hopkins right now, and so that allows me to extend, to my communities. So with that said, I appreciate you guys. Thank you for the honor of being here. Thank you.
Thank you.
So I think that's it, the report for this year, so we are here to listen to your opinions, critics, suggestions, recommendations, or whatever, so.
Well, we had a last part, which is the joking part, Persian or English, doesn't matter. Please invite from the audience who wants to come in to take the podium. Joke.
And who is ready to give us, tell us something humorous or joke? I said Dr. Mirabi.
Dr. Mirabi is the one, is probably the first candidate, right? Who wants to compete with Dr. Mirabi?
Dr. Mirabi, it will be good to hear your recommendations, whatever, if you come here, what's the joke, also tell us your experience. Dr. Mirabi is one of the ex-presidents of SIPNA and the pioneers and with a lot of experience, and also he was pushing that we need a new bylaw. So.
I didn't have no joke to say, no. Okay. I did it. I remember what my patient told me 40 years ago, but I cannot remember what he told me. I have no idea, it is amazing. I remember my patient, I've been practicing about 50 years now. I remember sometimes vividly, quoted back what they say, but for some strange reason, I think it has to do with my, it's like my brain. I cannot recall a joke after probably a few hours. Most everything else, and so, but again, no, let me put this way. First of all, as Dr. Shami said, I'm very pleased. We were, as of 2 days ago and yesterday, we were concerned, are we going to have anybody showing up? I really am feeling now more optimistic. I was somewhat optimistic about the survival. I'll be very frank with you. I was concerned that it might be the sunset of SIPNA. But after today's turnout, I think there is not going to be a sunset, it's going to be a sunrise, and it's going to be very shiny.
Wow.
That really takes an effort, team effort. You know what team stands for? TEAM. Together, each of us achieve more.
Bravo.
And we have, this young lady, President Dr. Baruti. I'm so pleased to say, I'm so proud of you. It's the young people gives us the reason to go on. As Dr. Shami said, some of us are the faucet, really. Dr. Maran is my good friend. We have I'm talking about myself, not for you. But we really need new blood, All we do, we have been through a lot, has been changes. When I became a psychiatrist, we had 3 antipsychotic, Thorazine, Esterazine, and Melarid, and we had 4 tricyclic, and 2 anti-anxiety, Valium and Librium. That was it. Okay. Now look at it. Thank God we have choices. As you all know, the only thing in life that is permanent is change. We have to capitalize on some of the changes, you know. There's more challenge, but also it's opportunity, you know. Sometimes we find ourselves there is a crisis. You know, I was in second year of my residency practice I was director of emergency psychiatry and crisis intervention in Houston, as you used to the 4 largest cities. By the way, can you imagine? I'm the only Iranian psychiatrist in the 4th largest city, the only Iranian psychiatrist. It's kind of sad, unfortunately. We had a couple of them, 2 of them passed away. One of them lost their license because of whatever. And so now, crisis, I was asked to give a talk on crisis. You know, I'm always say Chinese are going to take over the world. I was a young person, 2 years in practice, big shot, director of emergency psychiatry. I looked all, there was no internet. I looked all over the library to find the definition of crisis in different culture. I came to conclusion that Chinese had the best definition. You know what they define the crisis? Dangerous opportunity. So what is that? Dangerous opportunity. Then they elaborate. If we deal with a crisis, it can become an opportunity. But if you don't, it could be dangerous. We are encountering, unfortunately, not only in the neuroscience in our field, we are encountering crises throughout the global crisis, political, social, economical, spiritual, of course, scientific as well. Really, but at the same time, this is a challenge. How we, you know, maneuver all of these challenges. At the same time, there is no way anybody can do it, anything, you know, constructively by themselves. We need each other. I always remind the people, Barbara Streisand sang the song, people who needs people are the luckiest people. We all need each other. We are interconnected. I was reading a fascinating, this morning took a walk in the Nabil. I was reading the lead article by Dr. Preda, who is the new editor of Psychiatry News. I met him 2 days ago, chatted with him. You know what it's the concept he was talking about called mental tourists. If you get the PN news, read that. There's a second page, about almost 2 pages. Have you heard about mental tourists? You start talking about the Friedrich Nietzsche, the German philosopher, who said God is dead. That was his concept. Then he talked about Mr. Peterson, who was the priest in 1980, who came out with something different. What he was talking about is very, again, any of you get the Psychiatry News, read that article. I'm going to read one more again what he wrote. He's a very smart fellow, a young fellow. We have taken over about a year ago. So, what talking about is interesting. I could relate to it because it has to do with continuity. You know, there is no end. The end means in the Greek as telos. Have you ever heard of telos? I heard that a few years ago. Telos. Look it up. It's a Greek word. Talked about the goal, the end. Talking about the psychiatry, patient keep on coming is a continuity what helps, consistency. You don't want to end up having this mental tourist come and go. He also touched on the treatment failure. He said the issue is not so much that treatment isn't depression. People give up quickly as opposed to maintain consistency. I always tell my patient, 50 years, I never give up on anybody. Most everybody, anybody, no matter what, they can be helped. If You have the patient, if you don't give up, our patients don't give up, you know? They jump, they go places, especially these days with all of those, God knows, non-scientific approaches. Dr. Paramahar, yesterday talking about this emotional, what was it, emotional connection, something, the guy had this huge thing that you might have seen that in the exhibition. People, sometimes that is why they go to all of these, how should I say, the non-scientific issues, because it's a business, you know. So you should never give up, never ever give up on anything in life, you know. Nor about, you know, a week from today, I will be 85 years old. If you don't find me in my office, I will be one day here on the golf course, okay? I never look at age and number. I could have stopped working 15, 20 years ago. I don't want to. I'm helping people, but you know, because you gotta, as they say, if you don't use it, you lose it. You know, life is, you don't know what's gonna happen. Every day is God's day. And I just shared with you something talking about, I remember when I give you also a talk about some of the stuff that I have together, the concept of, I have presented that at the American College of Psychiatry. About, it's called total person. Total stand for, I remember when I do that, I don't know, I have to, probably takes me a good 30 minutes to present that to you guys. Total means I'm out to assess life. Person has to, I don't want to detail, but again, this concept, I've presented on the psychiatry. You know, we always can grow. I learned that from my late father. He said, you do not cease from learning until they put you 6 feet under. The two concepts I have is very oversimplistic. One of them is by 3A, Mirab is 3A's, and Mirab is 3L. We have to do a joke. I have no joke. Come on. The 3 A's are, you probably heard it before, attitude plus aptitude equals altitude. The 3L, living, learning, loving. If you live, you don't learn, how could you love? Love means caring, not romantic love. I stop that.
I just wanted to remind you and everybody else that few years after we started SIPNA, somebody came from Iran, introduced himself, I don't know the name. He was looking at different way of what we have been looking at SIPNA. When we finished talking, he said, you are just like dinosaur. You are just like dinosaur. You believe that you are going to survive, you are going to be eliminated as a physician, as a psychiatrist. Now I'm glad that he was wrong, and we are not a dinosaur. We get the dinosaur out, and we are rising, and we are showing that we are going to grow.
Now, Ms. Hashemi wants to tell us something about her own experience in short time that she has been in SIPNA.
So first of all, I want to say how amazing it is to hear how welcoming everybody is with the younger generation. When I first learned about SIPNA, I was actually searching for ways to support the study that I wanted to launch on Iranian mental health. And I thought, well, as somebody who doesn't really have connections in this field, how do I get to know professionals who've done this before, who've gone down this road before, who've done research, who've done this work? And I came across this organization. And I remember Dr. Eskandari was so delighted to have me in, and he brought me in as an intern and gave me this opportunity. And within one of our first sessions, all I thought about was how much other students and generally young people in this profession could benefit from knowing people who have been in this field for years and years. And so what idea that I was discussing with Dr. Yevgen was collaborating with Iranian student associations across different universities. In my experience, I can contact Canadian universities, but also American universities. Every year, there's more and more Iranian international students coming in who are coming into this country with very few connections in their field, who are trying to get their lives started, but don't really know how to begin. And so being able to have mentorship students, helping these kids essentially start their career paths down the field of psychology and psychiatry, which is getting more and more competitive every year, is essential. And so what we wanted to launch was essentially this program. If anybody is willing to take on mentors and students, this would be a wonderful opportunity to help incoming immigrants and even generally psychology or interested students. So.
So this was completely opposite of whatever you have heard. So they want your mentorship to help them to get to their goals. So that's very nice. Also, I welcome Dr. Mahbub Hamidi that we talked to, that she was APA Foundation ambassador, that gave us a talk. And the good news is that she has been more active in APA, and even today she has been accepted to be chair of the as students, correct? Chair of you get chair of one of the caucuses, so this. So we congratulate you for that, doing good job. And do you want to share anything with us, or?
Can I do it here or should I?
I think if you come here, it will be better. So.
Hi, everyone. I don't know if I have met you already, and if not, I'm Mahbub Hamidi. I call Vancouver, Canada home. This is, I think, about a year now since I've learned about involvement with SIPNA. I immigrated when I was 10 years old, but being Iranian is a part of my heart and something I hope to cherish as I hopefully climb up, leadership positions in organizations like APA, because I want it to be a recognition amongst the Iranian community that person's Iranian. I feel proud. And I'm very low on that ladder right now, but I just want to tell you the opportunity that I found becoming an APA Pass Ambassador. It was supported by SIPNA last year. Now, I just want to share with you how I have used that opportunity in terms of where I am today. So amongst the APA Pass Ambassadors, for the very first time, that program has existed for 2 years. I started a digital community peer-led support group for students and residents. There was 220 Pass Ambassadors joining that group. It helped address the hidden curriculum of attending conferences like this, how to navigate, where to go, how to combat imposter syndrome. I have received enormous support. I actually posted a small group photo of us today, which the APA actually reposted. So, we've got some recognition that way. And it turned into a survey that I have found a resident to collaborate with as a project, a program director from a program that actually wants to take on that project. She had a presentation here on leadership. So it leads to opportunities like that. Another thing that I'm trying to do is advocate with the IMG caucus. And in addition to the Global Mental Health caucus, the IMG caucus is one that I really will push for us to collaborate with as an organization, because they are doing work behind the scenes to help open up more routes for IMGs. And we have a lot of Iranian IMGs. That's going to be one way to support them. I actually have another project proposal in that regard to help address some of the barriers. I have a resident from Cleveland Clinic that's going to be collaborating with me on that project. And the IMG caucus president, I've actually talked to him this conference, is awaiting the finalized proposal for that project. So last year, I remember actually someone in this room asked me, what are you doing as far as research goes? I said, I'm still figuring out where I will thrive. And the two things I just mentioned to you are going to be research projects. that I'm now I'm gonna be the first author, but I'm also have support from a resident and a program director. And I think I can use these, pathway that I've kind of learned the ins and outs of to share these with other applicants in future cycles, so they can create opportunities like these for each other. One other thing I did, I am interested in child and adolescent psychiatry. One of the barriers for IMGs is when you go onto the membership websites, a lot of the resident or student memberships are free or cheap. But someone who's an IMG with year of graduation, more than a few years, they automatically get charged the higher fees. Sometimes that's going to be a barrier to actually signing up to become involved with these communities. So I'm advocating with APA now to make sure that barrier is removed. I advocated with ACAP. I've now made buddies with their membership director who actually removed that barrier for ACAP, which is why Ariane here was able to join me at the reception last night, because that barrier was removed. I'm going to be sharing that with other applicants. Sorry, I have maybe one or two more things to share. I don't want to take too much time. As part of the past ambassador presentation that I did, Dr. Ali Al-Badi was actually present virtually. I was able to, after that meeting, connect him with a research group. He is part of a group that is presenting a poster at ACAP this year. So I think the ACAP member director staff actually called me a bridge maker. And I think that's what I am essentially doing, trying to find bridges and create bridges to connect our community within these bigger organizations. Because as we grow and as we have more representation, it will actually benefit all of us. One other thing I did at APA is meet with someone heavily involved in SIPNA. That is the Pakistani Organization of Physicians, because they have an incredible model. They actually have even a curriculum where the American physicians have created courses that is accessible to Pakistani students, medical students in Pakistan. Because this year for me, as part of my SIPNA journey, the first step to any change is observing. I was observing other organizations, because to create a good model, you look at a good model, you find a good model. So he is now willing to, share with us any tips and tricks that they've done as a successful older organization to create changes for us. If it means rebranding, if it means doing things that will help bring in the younger generation of psychiatrists. With that, the proposal I have for SIPNA, if anybody wants to take it on, I'm willing to as well, is to review our mailing list, send out a survey, and this goes along with what you said. Who is, specializing in what? Who is an expert in what area of psychiatry? Are you willing to be a mentor? Are you working on research? Are you willing to guide a research project that's self-initiated? Up until last year, I had no research experience. Right now, I'm working on a case study and teaching 3 other students, and that was self-initiated. So maybe you might say I'm busy, but I'm willing to support a self-initiated, someone who's passionate to grow in this field. Maybe if we want to have webinars and we want to have active attendance, what if it's someone who's already an expert late career psychiatrist paired with an early career psychiatrist or applicant, and you work on that webinar together? That's also going to encourage attendance. The older generation, the incoming generation of psychiatrists. That's all I have to share. Thank you so much.
Wow, Dr. Hamidi, very proud of you. So as we said, this is our goal, that SIPNA be a stepping stone for all the young people at any age. We cannot just discriminate here, that they want to come with all ideas. When you come idea and if you have plans, you are free, and if we can do any help, you tell us how, we will try to help you. So this is, if anyone else has anything to add.
Dr. Giliana, do you hear me?
We should adjourn the meeting.
I have something to add.
Okay.
Anybody doing any research or interest in telehealth workers or telework providers? Or So the disparities that we're gonna have in the near future, I think it's a problem. And not only for mental health providers, but I think it's broadly across the world, internationally. Not locally.
I saw the,
Someone's proposing something?
Yeah, that's right.
What are they doing?
Unfortunately, I didn't get to go, but I was
Okay.
interested to see.
Yeah.
It was the like future of telepsychiatry.
Telepsychiatry, yeah, but with that, from a nursing focus on my doctorate, I'm doing some research on how it's gonna affect our policies and how we need to protect our patients in the future. And I started with mental health providers because, of course, seeing patients back to back, the toll it takes, the screen time, the sitting down. We're active people, we can't do that, but we don't know how to get up from the chair if that's where we are, so we need to educate, and then there's no research, so policy work now.
They keep postponing it.
Yeah.
They say like starting with Medicare.
Yeah,
or,
right.
As of such and such time, you cannot do telepsychiatry, and then the time gets near, they stop it, they change.
Increase.
And now they said, if you're on a stimulant, you need to be seen at least once a year,
Once.
which is not that bad. But a lot of therapists unfortunately also use this. I think the patient has to be face to face with the therapist.
I mean, and that's just the way access to care is now. But just it's gonna affect a lot of people's health.
Yeah.
A lot of providers, a lot of people that are sedentary and.
Yes, actually, telehealth, as you said, is most, the number of people that they were in telehealth before pandemic, there were not much.
Right.
But although it was there, but there were not much. And many, they were using it for many prisons or many correctional centers or those things that they were using it. When pandemic happened, they took the barrier away and said that every health provider, including mental health provider, who's licensed in any state can see patients in 50 states and all the territories. So during the pandemic, there was no, you could have talked with people at different state windows. But as the pandemic rules, the waiver went on. So now the main thing is that the provider can have telehealth if have license where the patient is. So, I'm from Illinois. I have license in California. I can do telehealth in California. I cannot do telehealth in Washington or Oregon or Arizona or anyone else, unless I see a student that goes there for a study as an emergency once or twice, and his home state is back in Illinois, for example. And you said if everybody use, I think all of us more and less somehow are using either phone session or video health, we are using it in practice. But the way that you said how it affects people or how it comes, I think they need more data that we get it, because as you know, Congress again just extend the limit for this many months or this many the end of the year. It's not indefinite. And I know that the American Psychiatric Association, American Medical Association, they want to make it indefinite. But still, we are not there, maybe because data is not there. And as you said, they want to at least in some states or that patient at least be seen once a year, face to face before. This is whatever we know. But your research, if anyone can be a help, just let us know. Otherwise, we wish you good luck.
Thank you.
Before we disperse, please get together for a
photo. Yeah, okay. So let's make that officially. We adjourn this 44th annual meeting. Hopefully next year we see each other in New York. Thank you.
Yes. Let's get together for a group picture to put it in SIPNA.net. Everybody would see it in the future. Wherever you want to get together, probably on the background you want to have that
Is
picture
Dr.
on the wall.
Mirabi nearby?
That would be great. Place.
Hello?
Let me set up my camera, and then we can remotely open the canvas with the spoke that everybody is in. Unless somebody,
Yeah.